Check one, two. Hello, check. ಇಲ್ಲ ಮ್ಯೂಸಿಕ್ ಪ್ಲೇ ಆಗಿಲ್ಲ. Check 1, 2, 3. Check.
Good morning. Can you hear me? Good morning to each one of you present here. Welcome to the second International Conference on ALS. My name is Ida Ioana, and I'm your host for the next 2 days. On behalf of Dr. Shyama Narang Foundation and MND, I extend a very warm welcome. And we shall begin the conference by invoking divine blessings and lighting the lamp by the dignitaries. I now invite the following to the stage to light the lamp. Mr. T.K. Anil Kumar, Dr. Pratima Murthy, Mr. Girdhar Gyani, Mr. B.S. Shankar Narayana Rao, Dr. Suvarna Aladi, Dr. A. Nalini, Mr. Vasant Rao, and Mr. Tupil Venkatesh. I now request each one of you to please light the lamp.
Kurutvam kalyanam arogyam dhana sampada. Shubham kurutvam kalyanam arogyam dhana sampada. Shatru buddhi vinashaya Deepajyotir namostute. Deepajyotir namostute. Deepajyotir parabrahma. Deepajyotir janardana. Deepajyotir parabrahma. Deepajyotir janardana. Deepo hartu me papam. Sandhya deepa namostute. O deepa brahma rupastham. Yogisha prabhuravyayah. O deepa brahma rupastham. Yogisha prabhuravyayah. Arogyam dehi putrasya. Vadik swachhami me sada. Yaverastam samarabhyam. Yavat suryodayo bhavi. Yaverastam samarabhyam. Yavat suryodayo bhavi. Yasya tishte gruhe deepa. Tasya nasti darindrata. Shubham kurutvam kalyanam arogyam dhana sampada. Shubham kurutvam kalyanam arogyam dhana sampada. Shatru buddhi vinashaya Deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam arogyam dhana sampada. Shubham kurutvam kalyanam.
Thank you, each one of you. At the outset of this international conference, I would like to express a few words regarding Dr. Shyama Narang, in whose memory this conference has been organized in association with NIMHANS. Dr. Shyama Narang was born in Bangalore, where she completed her schooling. She pursued her medical education at the People's Friendship University in Moscow, obtaining her MBBS and MD, and subsequently returned to India to practice medicine. In addition to her medical career, she actively participated in various social movements, including the Medico Friends Circle and the Women's Health Movement. Dr. Shyama Narang also took part in the Women's International Cross-Cultural Exchange Program in Geneva in 1985, working in Zurich for 6 months. She played an active role in numerous international women's health meetings. She was a strong advocate of the Shodhini Project, a research initiative on medicinal plants and women's health from 1987 to 1992. Dr. Shyama Narang was also known for her independent thinking and unwavering convictions. Even before the LGBT movement gained momentum in India, she actively supported an association of gays and transsexuals, serving as their president for several years. She also held the position of president at Mobility India, for an extended period. In this capacity, along with her team, she conducted disability audits for the Bangalore Metro Rail Corporation Limited Phase 1 Reach 1. Sadly, in 2015, Dr. Shama Narang was diagnosed with motor neuron disease. Despite facing this debilitating illness, she persevered in maintaining her independence and improving her quality of life. Throughout her lifetime, she aimed to establish a foundation that would inspire others to embrace the same passion for life. Despite all obstacles, unfortunately, fate had different plans and she passed away on September 2nd, 2019. In loving memory of Dr. Shama Narang, the Dr. Shama Narang Foundation MND Trust was established. Situated in Bangalore, the trust aims to raise awareness about motor neuron disease and promote excellence in the care and support provided to individuals with motor neuron disease. The founder trustee is Mr. Vasant Rao, husband of the late Dr. Shama Narang. I kindly request him to join us in welcoming our distinguished guests and honored invitees.
Distinguished guests, a very warm welcome to all of you. We are honored to have with us today Mr. T.K. Anil Kumar, Principal Secretary, Health and Family Welfare, Dr. Pratima Murthy, a Director, NIMHANS, Dr. Giridhar Gyani, Director General, Association for Healthcare Providers, India, Dr. B.S. Shankanayan Rao, Professor, Head of Department, Neurophysiology and Registrar, NIMHANS, Dr. Suvarna Aladi, Head of Department of Neurology, Dr. A. Nalini, Neuromuscular Specialist, NIMHANS, and Chairperson for this conference, Dr. Tupil Venkatesh, CEO of Foundation for Quality India and co-chair for this conference. We are also joined here by MND warriors, their caregivers, family physicians, doctors from various specializations, postgraduate students, researchers, speech therapists, occupational therapists, physiotherapists, faculty members of medical colleges and paramedical institutions, and their students, and our esteemed media, ladies and gentlemen. It's my proud privilege to welcome you all to the second Conference on Motor Neuron Disease. On behalf of the organizing committee, I express our sincere gratitude for your presence here today. As we gather here, we acknowledge the challenge faced by individuals living with motor neuron disease and the profound impact it has on the lives of those affected and their loved ones. It is a shared responsibility to deepen our understanding of this disease and their causes and potential treatment options. This conference provides an unique platform for experts from diverse backgrounds to come together, share insight, and their latest scientific breakthroughs. We've assembled a distinguished panel of speakers who will present their research findings, clinical experiences, and innovative approaches. The two-day conference includes 14 scientific sessions, including a panel discussion. The program is designed to facilitate robust discussion, foster interdisciplinary collaborations, and inspire new ideas that will help shape the future of MND research. Together, we have the power to make a real difference in the life of those affected. Once again, I welcome you all to this conference. Thank you very much, and do enjoy the conference.
Thank you, Mr. Rao. I now request Dr. Suvarna Aladi to address the gathering. Suvarna Aladi is Professor of Neurology at NIMHANS, Bangalore. Dr. Aladi specializes in cognitive and behavioral neurology and has around 20 years of clinical training and research experience in dementia and cognitive disorders. Dr. Aladi coordinates a multidisciplinary specialist service that provides comprehensive assessment, diagnostic services, treatment, and support to individuals living with dementia and their families. She holds several important positions in national and international professional associations. Please, Doctor.
So very warm good morning to all of you, respected dignitaries on the stage, Dr. Vasant Rao and friends who have assembled here. I wish I had known Shama Narang, but I think today with the introduction and with the gathering that is here, we feel we know her. And while she is not with us today, it is clear that her formidable energy is still going on along with the support of her family and the family of providers. So I'd like to congratulate Dr. Vasant for bringing us all together. On the behalf of Department of Neurology, we are committed to, sir, improving the quality of life of people with neurodegenerative disease, especially motor neuron disease, which is simply one of the most disabling conditions that we can see in our neurological practice. Professor Nalini has a really wonderful team of people, multidisciplinary group of people who are, for the last few decades, I think, Dr. Nalini, I remember her as a senior resident when she was very young. And since then, they have been providing tremendous service and basic research in the field of motor neuron disease. So we will all rededicate ourselves. Professor Pratima Murthy, for the last 1 year, through Sir Swasti Charan, has been, every time I see her, she says, Suvarna, do something for rare diseases. Do something for motor neuron disease. And we have got the mandate right from the top to do this. So this is really, really a great opportunity for us. We have healthcare providers, we have basic scientists, and all of us together, I think we just use this opportunity to rededicate ourselves. And this conference will just be the beginning of something more. Thank you very much.
I now request Dr. A. Nalini to give a brief overview of the conference. Dr. A. Nalini is the professor and head of Department Neurology. For the last 26 years, she has been actively involved in the treatment of patients with acute and chronic neurological diseases. As faculty at NIMHANS, Bangalore, she sees about 200 cases of patients with common as well as rare neurological diseases. She is actively involved in the teaching and training program of students pursuing their doctoral degree in neurology.
Thank you so much, and indeed honored to be associated with Dr. Shama Narang Foundation and in organizing this very important two-day meeting. Respected Director Pratima Murthy ma'am, beloved Registrar Dr. Shankar Narayan Rao, and all the enthusiasm-filled team of Mr. Vasant Rao and the dignitaries on the dais, and all delegates, patients, and the caregivers who are here. So in this two-day meeting, there is a galaxy of speakers with high expertise in motor neuron disease and in various aspects, from the clinical diagnosis to intense research, which is going on in this institute and elsewhere in the world. And we like to showcase this in this next 2 days so that everybody goes back with memories. So we as a team at NIMHANS have been involved with clinical diagnosis and research in motor neuron disease over the last 4 to 5 decades. And we are really working towards identifying a cause. Of course, all over the world, several top universities are really working hard to find a cause for this disease and then a cure, of course. And that looks very near to everybody looking at the research that is upcoming. So even as a student, my DM thesis was on motor neuron disease, and I was under the guidance of none other than the veteran MND specialist, Professor M. Gauri Devi, who's currently 84 years and still continues to give clinical services and diagnose motor neuron disease, and she's at Delhi. And tributes to her because she is the first person in India who really took up this research and clinical diagnosis in motor neuron disease, which otherwise had a nihilistic attitude by most physicians and most researchers that nothing can be done for this disease. But things have changed dramatically over the last several years, and it's moving forward that soon there may be a cure. and there is an endeavor. And I thank my entire team, Dr. Seena, Saraswati, Deepak, my Dr. Priya and team, Dr. Vijayalakshmi and team, with Professor Raju, Dr. Satyaprabha, who are all working relentlessly to find a cause for this disease with whatever best we can do with our resources at NIMHANS. And of course, we've also identified some biomarker which may be very important as far as treatment goes. So many here with young doctors and other residents here, we know that motor neuron disease, and that's the experience with most patients and with the relatives, the diagnosis is terribly delayed by months to years. So if they have a speech disturbance, they go to ENT surgeon and a cancer specialist also dealing with head and neck surgeries, and even to a movement disorder specialist. Many unwarranted tests and many unwarranted expensive surgical procedures like total knee replacement for somebody who has limb onset ALS. And we've seen such cases and the frustration and the tragedy that these patients have gone through apart from suffering from motor neuron disease. So in this 2 days program, we hope to and wish that we will be showcasing the clinical characteristics, how to diagnose and early diagnosis. And I say that every patient with motor neuron disease and every family deserves to get the diagnosis as early as possible, because everybody wants a closure. If I have a cancer, I want a closure for my case, and not that I'm going from pillar to post and doing doctor fetching to find out what is the disease. And then each doctor has a very highly focused thought process, and they're diagnosing and they're treating, thinking that this patient has got spasmodic dysphonia, this patient has got cancer of the larynx. So everybody is investigating, and then the journey of the motor neuron becomes even more painful, other than having to go through the motor neuron disease itself. So on this particular day of Motor Neuron Disease Global Awareness Day, I take pride in standing here and talking to the audience who have come here to listen and learn, and we hope that we do justice and in sort of sharing our gained knowledge over the years. And motor neuron disease in Indian patients is much, much different from the Caucasian population. We have a more than 4,000 cases registered in our NIMHANS cohort. And we know that MND in Indians is much different from the Caucasian. So we need to have our own research protocols, our own genetic testings, and our own pattern of management for the patients. So I wish everybody here that this meeting will be a successful one, and we will all take home very good messages and memories in the diagnosis and management of MND patients and their caregivers. Thank you so much.
Thank you, Dr. Nalini. I request Dr. Deepak Menon to hand over a memento to Dr. Nalini. I now request Dr. B.S. Shankar Narayana to address this august audience. Dr. Rao is the head Department of Neurophysiology and also the registrar of NIMHANS. His research areas are wide and include understanding the cellular and molecular mechanisms of learning and memory. Based on his discoveries, 2 drugs are developed and are in clinical trial phase 2 for treating mental retardation and autism. 2 more drugs have been formulated for treating neurodegenerative disorders, including Alzheimer's disease and aging. He has more than 150 publications in high-impact journals.
Good morning and welcome to NIMHANS for this important conference. It's extremely important that we have a great understanding of the movement disorder, specifically the motor neuron disease. And NIMHANS is been serving for more than 50 years, trying to understand the disease in great detail, but also evaluating the new strategies of treatment. At NIMHANS, we have a very comprehensive team to take care of the patients, try to understand the disease, and also the entire treatment regime runs into several weeks. And most importantly, understanding the pathophysiology associated with the disease that might translate into better treatment modalities. So as of now, we are restricted in terms of curing the disease completely, but we are managing the patients. But we should evolve the new treatment regimes that comes with understanding the disease in great detail. I'm sure that the next 2 days of the meeting, we are going to discuss and deliberate and try to understand each one of those components in great detail. And discussions and learning from clinicians and the researchers will try to take messages from the clinical approach and try to see that what is the best way of evaluating the new treatment regimes as such. So on behalf of NIMHANS, I take this opportunity to welcome each one of you. And also I welcome the chief guest, Dr. T.K. Anil Kumar, and all the dignitaries on the dais and off the dais. And you have a very focused speaker who is going to share it's more than 2 to 3 decades of their experience, try to understand the disease in greater detail. And each one of those components will be a learning exercise for us. And I'm sure that he will find some time to visit the NIMHANS as well. And it's a mutual learning exercise for each one of us. Thank you very much. Namaskar, Dhanyavad.
Thank you, Dr. Rao. I request Dr. Saraswati Nashi to hand over a memento to Dr. Rao. I now request Dr. Girdhar Gyani, our guest of honor, to address the gathering. Dr. Girdhar Gyani is the Director General, Association of Healthcare Providers India. The mission of association is to build capacity in Indian health system with focus on providing universal health coverage to community at large. He played a pivotal role in formulation and operation of National Accreditation Board for hospitals and healthcare providers. He is also the Secretary General, Quality Council of India. And for his work, SME World magazine, in its cover story of June 2012 issue, described him as Quality Man of India.
You are already tall. Why you are using this? Okay. Okay, good. Secretary Health, Government of Karnataka, Director NIMHANS, ladies and gentlemen. You see, this MND, of course, we all know is comes in the category of rare diseases. When Dr. Vasant was formulating this foundation, so I, because I keep participating in the meetings at Niti Aayog or Government of India, so I used to inquire from them what actually are their plans for rare diseases. So they showed me the document that it is built into the policy, and the Department of ICMR, Department of Science and Technology, CSIR, and Department of Pharmaceutical. They are supposed to be working on research and supporting the development activities for the diagnosis and the treatment. So it is built in. But the problem is that no funds have been allocated. In fact, I used to share with them the kind of money allocated by at least 2 countries which I am very familiar, the United Kingdom and Australia, because we interact with them on quality and patient safety issues. They have allocated huge money on diagnosis and development. But the answer from the government authorities in general used to be that first let us build the basic blocks for healthcare. Then we can focus on the rare diseases. I said, why can't we go parallelly? But sometimes you have to accept the reality on the ground. Because if I am studying or part of the healthcare movement in our country, I just can tell you some of the students are also sitting here. The healthcare becoming political agenda started way back in 2007. And I gave credit to Mr. Rajshekhar Reddy, who initiated the Arogyashri scheme, bringing healthcare to the doorsteps of the underprivileged people. Then, of course, it was followed up by government of Tamil Nadu, Karnataka, but the mega scheme, rather the mega initiative came in 2017 when government came out with a new health policy. It has a lot of features, of course, I will not discuss it here, but that was quickly followed up by the world's largest healthcare insurance scheme. You are aware about it, Ayushman Bharat, which is supposed to cover 40% of India's population for the insurance. Immediately next year and next to next year, 19 and 20, we have launched the National Digital Health Mission. Now that intent now is very focused and very clear. I keep saying that if these two schemes become success or they mature, which I'm expecting next 5 years, then of course India will be in the forefront of, I can say, in the league of developed nation as far as healthcare is concerned. In fact, we have coined the phrase that India can become the Vishwa Guru in healthcare maybe by 2047. But anyway, that is a side story. So coming back, to this further dialogue, which I keep having in the Ministry of Health. So, we actually keep seeing the data. Where are we lacking? Because they keep saying that basic building blocks have to be made before we go into the rare category of diseases. So, the fact comes out that we have around less than 1.5 beds per 1,000 population. 1.5 bed per 1,000 population, as against the requirement of 3.5 beds per 1,000 population as per WHO. So we have to more than double the number of beds. Then we did, based on the, requirement from Niti Aayog, we worked out based on data from our association, and we learned that there is a great disparity. Bihar, we found 0.3 beds per 1,000 population, 0.3 beds. While the highest number, you can guess, it can be Tamil Nadu, Kerala, or Karnataka. Can anybody guess which is the state having larger number of beds per 1,000? Kerala? Yeah, that is, I also initially used to think Kerala. But actually it is Karnataka. Secretary is sitting here. 4.2 beds per 1,000 population they have. They means Karnataka has, which is more than the WHO requirement. And Kerala is having 3.0 beds. Now, within Karnataka, I was discussing with Secretary in the tea time that he can find out even within the Karnataka, there will be, of course, disparity. Overall, they are good, 4.2, but there will be disparity. So I think we have to we have to target these aspects of the healthcare before, we really start focusing on the rare diseases. Nevertheless, we have been working with the NMC on various issues, and recently you have seen the curriculum has been revised. And yesterday we had a meeting with Dr. Vinod Paul in the Niti Aayog. And I think he strongly suggested me, because I knew that I am coming here, so I discussed this point also. And he suggested that we should have small SOP, small protocol. There is no standard treatment guideline for our RMOs, nursing staff, for the doctors, at least geriatric care, for example. MND, of course, is definitely there. At least we must make them aware about it, that this is what it is, so that when there are patients, because this helplessness should go. We have helplessness. Oh, MND, sorry, nothing can be done. I think that has to go. That is very dangerous, aspect in our concept. So, and another thing which we are going to work, of course, NIMHANS is the right institute which is holding this conference to take the lead role in this direction. But we are going to tell government that firstly, we have to create registry of all the patients who are coming within the various hospitals. So this should be like tuberculosis. We must make it mandatory to have a registry. While government can do it, we have taken a decision in our association. We have 21,000 hospitals as our members, that at least we will create a voluntary registry so that there can be sharing of the knowledge, various treatment, what is the behavioral aspect happening. So this is few things I think we are going to do. But otherwise, I think I have only one point, from bottom of my heart, I want to, thank that when you do the Google search about MND, you will find only MND Trust coming as far as India is concerned. So I think more than government, you have taken the big initiative. We are all with you, and God bless you. Thank you very much.
Thank you, Dr. Girdhar Gyani. I now request Dr. Seena Vengalir to hand over a memento to Dr. Girdhar Gyani. I now request Dr. Pratima Murthy, Director of NIMHANS, to address this august audience. Dr. Pratima Murthy, Professor and Head of the Department of Psychiatry, NIMHANS, took charge as full-term Director of NIMHANS on 18 June 2021. She joined as a faculty at NIMHANS in 1993 and has worked in various academic capacities.
Okay, she doesn't want to be spoken about. Please carry on. She'll speak for
I'm
herself.
sorry to deprive you of that opportunity, but I think that's not necessary at the moment. First of all, good morning to everybody. And I'd first like to actually invoke Dr. Shama Narang, because I think without her, in some ways, this conference would not have occurred. And therefore, I think we must spare a moment and really acknowledge the suffering that so many tens of thousands of people, even if it's a rare disorder, in India, we have a substantial number of people with MND. And I think it's so important in some ways that she brought us all together to make sure that we can help the tens of thousands of people who need our help. Mr. Vasant Rao, congratulations for your grit and determination. I met you last year when we did this conference online, and his enthusiasm and his dedication was very apparent just a few moments ago. So, sir, I wanted to thank you from the bottom of my heart for actually, again, bringing us all together and for making this conference a conference with a difference. And I think it was mentioned by the earlier speakers that this is a unique conference because it's not entirely organized by NIMHANS. It is with your initiative and with the Shama Narang Foundation. And I hope we see a lot more of such collaboration occurring, because finally, that's how it also puts clinicians and scientists' feet on the ground to really understand the needs of people, so that we can actually try and meet those needs rather than work in isolation of each other. I also wanted to acknowledge the presence here of Mr. Anil Kumar, our chief guest for today, and as the Secretary of Health in Karnataka, he's been a very important go-to person for all of us. And I especially wanted to mention, sir, of course, NIMHANS being in the area of mental health and neurosciences, it's in these areas that we interact with you. So I'm sure there have been a huge number of contributions that you've made in other spheres of health also, but particularly from our vantage, the fact that he's driving the mental health program in Karnataka, which has become a flagship program for everybody in the country. And secondly, for your leadership in initiating the brain health initiative, in Karnataka, which really, again, talks about demystifying neurological disorders and taking those disorders to the community so that we can have a good understanding and the early recognition and possible intervention for people with various kinds of neurological disorders. Dr. Giridhar Gyani, it was a pleasure to listen to you and your commitment as the DG of the Association of Healthcare Providers. And certainly, I think you mentioned the issue about rare diseases. I think the government is taking this forward. And as we have many rare diseases to look after in our armamentarium, this particular initiative not just provides finances for research, but also support to families and patients who need to live with this disorder. So it is very promising. And in that context, again, I wanted to congratulate Dr. Nalini and her team on their leadership in the area of MND as well as neuromuscular disorders, where we have now a center of excellence. Of course, as we all know, we have many centers of excellence at NIMHANS. In fact, every center is a center of excellence because everybody is doing their wonderful bit, but the finances are finite. And therefore, I think we also we need to see who will support us in these ventures. And we need to extend beyond governmental organizations to philanthropy and various other possible support systems so that the entire spectrum from early diagnosis, including perhaps genetic diagnosis and counseling, all the way to treatment as well as rehabilitation, we can take care of patients. Just this morning, we have once a month, we have a presentation from various departments. And today the Department of Speech Pathology and Audiology made their presentation, and they are doing phenomenal work with the Department of Neurology, Neurosurgery, and Psychiatry, particularly here to look at speech and swallowing difficulties, Our physiotherapy and occupational therapy department are looking at locomotor rehabilitation and that. So we have an entire, army of people to look at various aspects of the disorder. But then look, I mean, human beings live on hope. And our hope obviously will be that we find a way of curing this disorder and of preventing this disorder. And that is only possible through proper research, through looking at genetic mechanisms, to really being able to get to the root of it, to be able to. So we live in the hope and aspiration that we will one day find a cure for it. And I hope that's not too far away. But obviously, we cannot simply live on hope. We live in a real world where there are real patients who need help, not just symptomatic help, treatment of comorbidities, but also need help to be as independent as possible and to get on in life with the support that we can all provide as a caring society. I'm very happy that there are family members as well as sufferers from MND who are also present in our audience. And we will assure you that whatever is possible with ourselves, with our strengths, and whatever we can get together in terms of an organized society to help you with these conditions, that we are committed to do that. I know in our midst, we have Dr. Tupil Venkatesh, the lead man. That's the way you're introduced all over. So I guess we'll have to, do that. We have several other dignitaries who have a huge amount of experience in the area of MND. And I'm sure the audience, which is a good mixture of students, family members, faculty and researchers who are doing work in this area, will really be able to learn what the state of art is and how do we take this forward. My friend Dr. Vengama is also there in the audience. A special welcome to Dr. Vengama, to her alma mater. And I wish you all a good conference. And let's hope that we continue to strive. Each of us has an important part to play in this whole, in the management of this disorder. And I hope each of us will be able to play a part, rise above what we are capable of, to get together and make life meaningful, as well as look out and live in hope and aspirations that we will get a cure one day. Thank you very much.
Thank you, Dr. Pratima Murthy. I request Mr. Vasant Rao to hand over a memento to Dr. Pratima. I now request our chief guest, Mr. T.K. Anil Kumar, IAS, to address the audience. Mr. T.K. Anil Kumar is the Principal Secretary to Government, Health and Family Welfare Department, Karnataka. After completing his BTech in Mechanical Engineering, he qualified the civil services and joined the services in the year 1995. He has worked as secretary in different departments like urban development, DPAR, housing, tourism, and medical education, to mention a few.
Dr. Pratima Murthy, Director NIMHANS, Dr. Giridhar Gyani, Dr. B.S. Shankar Narayan Rao, Dr. Suvarna Alladi, Dr. A. Nalini, Dr. T. Venkatesh, Vasant Rao, ladies and gentlemen and friends. It's indeed an honor and a pleasure to be a part of this two-day international conference on ALS and MND. I understand that we have with us not only scientists, healthcare professionals, caregivers, but also the MND warriors as well. So it's a rare privilege for me to participate and be a part of the inaugural session. Let me begin by congratulating Mr. Vasant Rao and the Dr. Shama Narang Foundation. As Dr. Pratima Murthy put it, the passion with which he has been moving towards finding a cure for MND is really, the only reason why I'm here is Mr. Vasant Rao had met me last week, and the passion with which he was expressing his ideas and wanted to find solutions to the issues that he had faced on a personal note. So I congratulate the foundation, and also congratulations is also due to NIMHANS. I mean, NIMHANS has been partnering with these kind of organizations and trying to find solutions to problems in the society. the state of Karnataka is blessed that we have an institute like the NIMHANS. It's a institute of national importance, and we have been collaborating with the institute, as Dr. Pratima Murthy mentioned. So initially it started with strengthening of the mental health program at the district level. Subsequently, the Telemanas program, which was rolled out, and now it has become a national level program. We are on the annual of yet another program which is likely to be now replicated in other states, the Brain Health Initiative, which was rolled out in 3 districts and has provided rich dividends. The intention is that we should not limit our knowledge to institutes or to a few hospitals. The idea is that it should go into society, people should gain from them, use existing systems. So what happened in the Brain Health Initiative is that our doctors were trained, a hub and spoke kind of a model. The information in NIMHANS was sent not just to the district or the taluk level, but right down to the village level, where people could add a lot of value to mental health issues. So at this juncture, I think I would like to mention, even in the case of rare diseases, since as Dr. Giridhar Gyani mentioned, as policymakers, we tend to address big problems, because if there are a lack of people who are afflicted, so our focus is it goes towards that. So the rare diseases has not got the attention that it deserves. Of course, there is a policy now in place, and there are high court and high court rulings that have come about, and the government is being nudged into that direction of addressing rare disease issues. Probably funding may be an issue, may not be an issue, but I think some amount of leadership will have to be provided. I think I'm very happy to note that NIMHANS is providing that kind of support, and we're trying to find a solution. So on behalf of the state of Karnataka, we are willing to work on these rare diseases, partner with organizations like the Dr. Shama Narang Foundation and other foundations, so that we can use the kind of knowledge that you have and try to help a larger set of people. So we can work towards getting it, getting partnership with institutions that already exist. So there is a lot of work that is already done by the Institute of Child Health here in Bangalore. They work on rare diseases, so it could become a nodal point for these kind of rare diseases, and we can take it forward. So we will have an engagement, both with NIMHANS and with Vasant Rao, and try to take it forward. I will not take too much of your time. I think there are a lot of people in this room with huge amount of experience. There are caregivers and the MND warriors who are willing to share their ideas. And let's hope that we move in the direction of finding a cure for MND. I wish the 2-day conference all the success. Let there be a good deliberation on the topic, and you find solutions for the problem. I once again thank the organizers for inviting me to this conference. Thank you one and all.
Thank you, Mr. Anil Kumar. I request Dr. Bhargavi to hand over a memento to Mr. Anil Kumar. I now request Dr. Suvarna Alladi and Dr. A. Nalini to release the handbook brought out for the occasion. I now request Dr. T. Venkatesh, co-chair for this conference, to propose the vote of thanks. Dr. Tupil Venkatesh is the Professor Emeritus. You will speak for yourself as well. Okay. Please.
I would like to take 1 second. We have a few MND warriors here, caregivers here. Deepak Vikram. I have Mr. Deepak Vikram here. I have Dr. Venkat Subaya, and I think Amitu is here. Mr. Amitu. Okay, I will kindly request you to come over to the dais and receive one copy. Madam, here is the.
Chancellors, vice chancellors, directors, secretaries, caregivers, most important, our MND ALS representatives. I don't want to call them patients. I and you can be that representative one day. If I don't thank Anil Kumar, he will not feel bad. Am I sure? If I don't thank Dr. Pramila, Pratima Murthy, she will not feel bad. If I don't thank Giridhar Gyani, he will not feel bad. If I don't thank other Dr. Nalini, all other dignitaries, they will never mistake me. If I don't thank all of you, you will not be upset. But we are all here. You must remember, because of only one group of people called MND and ALS. If I don't thank them, because of them we are here, every one of you will feel bad. My gratitude, thanks for learning from them, but still we have a lot of challenges ahead of us. We have a lot of opportunities ahead of us till the day when we make their life comfortable, till the day we make their life like your life and my life. I cannot thank anybody. I have a message to all of you. Dr. Shama Narang is alive today. Vasant, she is with us today in spirit. Whenever I see you, Vasant, I see Dr. Shama Narang. I get emotional when I think of people like Dr. Shama Narang. She is one amongst us like any other family member amongst us. Professor Gustavo, I'm sure you will agree with me, traveling 42 hours by flight and reaching yesterday morning here. I tell you, all of us belong to only one family of how to make their life like your life and my life. Let us now express our gratitude for giving us that opportunity to understand them. Let us thank them for showing us the path. Let us thank him, thank them. I tell you, I don't know, from the bottom of my heart I'm expressing, but for you, we would not have had this conference. We don't have a long way to go. I tell you, we can achieve, we shall do it. It is not the position we have, not just the knowledge we have acquired. It is the care, compassion, what we have, with which we should be able to come close to you. Thank you very much, my dear. Thank you. Thank you.
Thank you, Dr. Venkatesh. I now request all the dignitaries to kindly be seated in the front row. for the scientific session.
I'm Suvarna. She is Nalini. She is the
You are the next thing, your presentation. Yeah, I know. Have they opened? What is it called? Yes, of course. Suvarna, the directors all going there, just go with them. So let's not postpone the wait. Let's start. Let's start. Wait. Relax. Okay. Break time.
We'll now have Dr. A. Nalini to give her talk on clinical phenotypes and diagnosis of MND.
Let's start. Do you want to dim these lights a bit, or is it okay? So, good morning, everybody here, the young doctors, residents, faculty, and all the other dignitaries. I'm really honored to be the opening batsman and speak on the clinical aspects. I think the delegates who are coming, just keep coming forward and sitting, okay? And maybe we could have the door closed for some time. Okay. So I'm just going to cover up quickly. The timer is on already for me. So let's start with the basics of what's the clinical phenotypes, and nothing much I'm going to go on diagnosis because it's not very, very important. So let me just tribute to our Professor M. Gauri Devi, who's, oh, this is the one, is it? Okay, we can have the other pointer, please. Okay, this is LED screen. So way back in 1984, can you believe that she conducted this MND symposium almost 40 years ago, when there was no internet, there was no computers, there was no mobile phones, just through letters and postals, she was able to bring in the giants working on motor neuron disease. And I'm sure that everybody here knows that we talk about, I think I need the other pointer with the green, not this focus light. With the Professor Hirano, you would have read about Hirano bodies, which was first described, and she brought in even a Nobel laureate like Professor Gadjusek, you all know, and these are the top guns. And of course, most of them are not there now. Dr. Bradley. So unimaginable that in 1984, Madam Gauri Devi, and I was her student, disciple, and she continues to be my mentor and teacher. So with that, let's just start. And we started the motor neuron disease or the neuromuscular disorders clinic way back in 1991, and we have registered more than 3,000 cases of ALS in this clinic. And of course, we cater to the various forms of neuromuscular disorders. You can see the rehabilitation specialist, Dr. Anupam, Dr. Priya, our Dr. Former Chief Prakashi Madam, and all my PhD students and all my residents who have been part of this journey of the clinical evaluation, research, and outcome that we have checked in to do with motor neuron disease. So what's the mandate of motor neuron disease? This is since 1976. So basically clinical phenotyping and scoring. Then we have genetic testing, neurophysiological assessment of these patients, advanced speech analysis and dysphagia management. Of course, all of the experts are going to speak on these various aspects today. Imaging in motor neuron disease, which has taken a very, very important step in identifying the pathophysiological processes that happen in motor neuron disease, the iPSC stem cell work, which goes on with physiology lab, Dr. Vijay Lakshmi, Dr. Satyaprabha are here, and of course, the MND palliative care, which is the most important in taking care of patients, because till there is a cure, we have to take care of them symptomatically. So this is how we take care of our patients with MND ALS. Dr. Priya's name I have imprinted there, and Dr. Kirti, thanks Priya for being part of this team for several years now and taking this forward. through a CSR project. And we want the government of India to support us and government of Karnataka to continue support us in this neuropalliative care, which is the main purpose of management of motor neuron disease. So into the basics, like Charcot was the first doctor who described this way back in 19th century. And it's one disorder which is quite classical. It's a teaching case. It is an exam case for MBBS graduates. It's an exam case for MD students as well as for DM students. And it evolved over the pathophysiological features which were identified during autopsy with sclerosis of the spinal cord. And this is one disease where you have a combination of upper motor neuron and lower motor neuron in a particular region of the body, be it the limbs or the bulbar muscles. So it has a very wide, so it doesn't mean that each patient with MND is the same. It's not a stereotype disease, and it could affect the limbs, or it could affect the bulbar muscles, or it could just affect the cognitive functions. And most cases, as we know, are sporadic, almost 90 to 95%, whereas 5 to 10% are familial cases. And usually the ultimate end of this disease is death from respiratory failure, generally within 5 years of onset, but of course, Indian patients do live very, very long. So prevalence, as you can see, much more in the northern hemisphere, like in Canada and the US, and much lower in the South American population, and mediocre in the Indian population. So that's about 1 to 4 per 1 lakh population. So coming to etiology, still we are not sure of the true etiological factor that causes MND and loss of motor neurons, but several things like abnormal RNA processing, SOD1. Of course, today SOD1 is a major aspect of therapy, and already there are drug trials which is genetically mediated. Excitotoxicity with glutamate, which is the only approved drug, that is riluzole, which is again excitotoxic glutamate. Mitochondrial dysfunction, infections precipitating or triggering motor neuron disease, and many others. So how do we diagnose motor neuron disease? There are several criteria which came up in 1994, the LS-Coriel criteria, which was modified, the Awajishima criteria, and of course the Gold Coast criteria is the latest, and it is quite simple. And this is because we need to catch ALS patients before they become definitive cases. So we need to, if there is any drug treatment, we know that most of the degenerative diseases, 80 to 90% of the cells are lost by the time the patient manifests with the disease. So we really have to catch them when it is very, very early. And so high degree of suspicion is required in diagnosing these cases. So very simple Gold Coast criteria for ALS. So you have a combination of upper motor neuron and lower motor neuron symptoms in one limb. Like I said, ALS is one disease where you have a combination, a wasted limb will have brisk reflexes, which you'd hardly ever see in any other condition. And it still remains a bedside diagnosis. That's where we clinicians are so important in diagnosis, that we do not have a definitive biomarker to diagnose this disease. And still it's a bedside diagnosis based on the clinical features and the clinical manifestations and the evolution of the disease. And we rule out other causes which might, what we call as mimic ALS, or just look like ALS, but they're not true ALS. So what are the phenotypes? You know, the classical one is the limb onset, where you have wasting weakness of the distal muscle, which progresses to involve the proximal muscles, and it spreads. It can spread like in an inverted U, like one upper limb, another upper limb, lower limbs, or in a U pattern, or a Z pattern, or an X pattern. So any of these patterns can involve, and usually classically MND is an asymmetrical onset disorder. It can start with the bulbar muscles, which call it as a progressive bulbar palsy, then progressive muscular atrophy, flail arm syndrome, flail leg syndrome, or what we call as the pseudopolyneuritic form, very important because most of these are misdiagnosed as neuropathies. A progressive pseudobulbar palsy, we've seen such patients going to the psychiatrist for many months, and then they come to us only when they start developing dysphagia. And of course, the hemiplegic variant, where the patient can go as like a evolving stroke. So in MND, the disease progresses what we call as region by region. Like for the residents, like for spondylotic myelopathy, we have what is called as the Ellsberg phenomena. But here it's region. If the right upper limb affected distally, it goes to proximally, and then the left upper limb distally, proximally. So MND progresses region by region. And that focal area, whichever is involved maximally, will have a combination of UMN and LMN findings in it, like a wasting weakness and exaggerated reflexes. So that's the combination. So what's this epidemiology, the demographics of ALS tell us? The incidence is about 2 to 3 per 1 lakh population in the Europe, and it's about less 0.7, as I already showed you in that diagram. And the prevalence is about 4 per 100,000. So males are more affected than females. It's about 1.5:1, but of course our study shows that it's about 3:1 with the Indian population. So many more men are affected. It's not that women are not brought to the hospitals, but it's a fact that more men are affected than women. And you can see based on the age, you can call it as juvenile ALS. You have a young boy sitting over here with onset between 25 to 48 years is young onset. 45 to 75 is classic ALS that we see, and more than 70 years is old onset. So this is the Caucasian studies that death usually occurs within 3 to 5 years, but not to be disheartened that Indian patients live as long as 8 to 9 years and at some time as long as 15 years. So that's important for us to Indian and our Indian doctors. I know that I used to tell my patients way back 20 years ago saying that they would ask me, how long is my patient going to live? I would tell them maybe 3 to 5 years. And they came back to me after 6 years and said, doctor, we've proved you wrong. You said 3 to 5 years and my patient is still living. So I had to be very, very cautious till we did our own analysis and we saw that our patients live for very long. It's possible that the Indian patients, the onset of disease is almost 1 decade earlier compared to the Caucasians. So there is a good neuronal reserve, what we call. So the neuronal reserve is something that prolongs the life or keeps the Indian patients living longer. Whereas in the West, it may be in the 60s or 70s. So the neuronal reserve is very less and there's a rapid loss of this existing small pool of normal neurons. So that's one of the reasons which has been postulated for the long survival. And also, of course, the families matter, the love and affection that they get in families, and the caregivers still in India, and they're not put into institutions as soon as a MND diagnosis is made. So we know this is a disease. It's a clinical entity. I once again stress that clinicians have to be so careful in diagnosing this case and just don't give arbitrary diagnosis to patients, anterior horn cell disease, under observation, but try to make a diagnosis. So as I said, every patient and caregiver wants a closure for their disease, and be sure and not go doctor fetching everywhere. And there are no laboratory biomarkers. So we need to really make a good bedside clinical diagnosis. And many symptoms like fatigue, cramps, and fasciculations are often overlooked. And so tendency for doctors or the general practitioners to keep misdiagnosing or taking, a lot of time is lost in this. And possibly a day will come when we have to treat ALS as early as possible. And that's when the diagnosis becomes very, very crucial. So this is our study for more than 1,153 patients that we did way back and published in 2008, more than almost 15 years ago. And we found that, of course, as I said, 3:1 is the male is to female ratio. And the age of onset is almost 1 decade earlier, like around 46.2 years. And women were affected much later on in the illness. And a large chunk of them, you can see they were less than 30 years of age onset. And you can see one of our patients sitting here. So we looked at the survival of a small group of patients who died secondary to ALS, and none of them had received any supportive measures of either BiPAP ventilation or ventilatory support or feeding gastrostomies. And they did survive. As you can see, they lived pretty long as 15 years with the limb onset ALS. And even the bulbar onset ALS lived pretty long. So the Indian patients are different from the Western population. And also many of our patients refuse to take PEG because Indians like to taste their food. So they want to have food even till the last morsel that they can eat and swallow. So they refuse having feeding tubes, whereas Westerners accept feeding tubes very, very soon. So as I said, we have the spinal onset. Classically, you have the limb onset muscles where you have wasting, weakness of the limbs. And calf muscle cramps, they can have for several months to years sometimes before the wasting and weakness starts developing. So that is one of the very initial clues of motor neuron disease. And they may have occasional fasciculations, which is just, passed off as a normal phenomenon. And as I said, the weakness and wasting spreads from one region to the other region, and the patients have generalized fasciculations. We know that fasciculations is a sine qua non of anterior horn cell disease. Somebody who has wasting, weakness, fasciculations, cramps, your diagnosis is almost your right if you make a diagnosis of motor neuron disease. And we do not know till date why bulbar muscles get affected, why limb muscles get affected, or the pseudobulbar fibers get affected. So that sort of a proclivity for a certain region is yet to be, it's a challenge that scientists have not yet been able to decipher. So what's the disease course? Not to be disillusioned, our patients and caregivers who are here. So usual course, like 1 to 5 years, a person about 80 years who comes with ALS may have a shorter course of the disease, whereas a younger person, and approximately 50% may lose their life by the end of 3 years. These are all the statistics from the Caucasian population. And more than 65 years, the duration of illness may be much shorter. But most important is that one cannot time the onset of disease in these patients. So classically, this is for the students. As you can see, there is severe wasting and weakness of the hands, which is very, very classical. You can see the thumb muscles are affected, the tongue is wasted, and this patient is quite advanced. You see there is an increased basal metabolic rate in ALS, and they tend to lose weight even after good amount of nutritional feeding. So these are all our patients, and you can see the saliva drooling because they have so much of difficulty in swallowing. So bulbar weakness. So I know that all of you all are familiar with the electrophysiological processes, particularly EMG, which is a very painful procedure. So of course, now we know that we can do a very painless procedure like ultrasound of the muscles. Choose any muscle, including the genioglossus. Just put the probe at the neck, and then you can see the fasciculations. You can see very, very nicely seen. This is in the triceps muscles with one of our patients with the young ALS and fasciculations. So we literally moved away from the painful procedure of electrophysiology of EMG and then gone on to ultrasound. So it's even in the tongue, one can I'm sorry. So this is the tongue you can make out. This is the tongue. This is the mylohyoid muscles. These are the digastric muscles. You can see the twitches of the muscles. So we know that there was a day when they put the needle right into the tongue to look for fasciculations, into the genioglossus for the fasciculation. Such a painful procedure. Well, I've not done it because I always thought it's going to be painful. But now with this ultrasound of the muscles and ultrasound of the tongue, it's been such a rewarding and technology which existed, but which was not found to be used for long. So in advanced ALS, of course, we have patients who have problems with breathing. We put them on BiPAP machines to support their breathing, the ventilator. Otherwise, they go in for daytime somnolence, fragmented sleep, irritation, restlessness because of carbon dioxide retention. So deciding with the pulmonologist around and taking care of them with the respiration becomes very important, because we want to give a good quality of life for patients as long as they live, although there's no cure. But we need to have even for the caregivers, even the caregivers are not going to sleep if a patient is going to have fragmented sleep, and they're going to be turning, tossing. And then of course the feeding for the nutritional status, and there's a point of time when patients can't swallow even their saliva, and at that time we really need to get into this feeding tube, and one is for nutrition and one is for the hunger, that all of them have normal hunger. So we know that what should not happen in ALS when you're making a diagnosis. So eye movements have to be intact, because we know that the oculomotor nucleus is preserved. Bowel and bladder functions are retained till the end. Peripheral nervous system, like the sensory or the autonomic nervous system, the vision and hearing and taste is not affected. And these are all striking. But of course, we know as neurologists that as the disease advances, and particularly in the genetic forms of ALS, we can have all of these affected. But for a student, for a resident, for a medical graduate, we know that MND is a pure motor disorder. And we should, if we have these, we have to doubt a diagnosis of ALS. It could be symptomatic, it could be cancer related, it could be endocrine related ALS. So we have to go all out, looking out for other causes of ALS. But we know that at the end, MND is a multi-system disorder. We can have cognition. Dr. Suvarna is going to elaborate on that. We can have sphincter involvement. Autonomic dysfunctions can be, but they're not profound. Yes, they can be there, and including apraxia. So apart, the classical one is the limb onset. Now with the bulbar onset or the pseudobulbar onset, the speech is the first one to get affected, dysarthria followed by dysphagia, difficulty in swallowing, and some can have vice versa. We know that neurogenic dysphagia, you can have swallowing for liquids much more difficult than solids, whereas in cancer patients or any growth, solid dysphagia for solids is much more than liquids. And I know that patients go to ENT surgeons, have gone to cancer specialists. The moment I have speech, they say, oh, it must be having laryngeal cancer, pharyngeal cancer, but that's it's important. And then a lot of time is wasted in that. And they do progress. We know that bulbar onset is more common among women. And this can be highly associated with cognitive involvement and also with pseudobulbar features like emotional incontinence, excessive laughter or crying, and maybe depression as well. So sound is not there. So this is a patient with classical spastic dysarthria with ALS. That's Dr. Sina talking. So her tongue movements are completely lost. And you can see it's wasted, it's atrophic, okay? And the speech is very effortful. It's very labored speech. And then you have, so I know that with Dr. Yamini and group from Indian Institute of Science, we are doing a lot of work on creation of apps. So yeah, I know Yamini is here. And then you can have an app. If you have altered speech, you just speak into the app and the app is going to tell you whether you have ALS or Parkinson's disease. Like we've recorded almost 400 ALS patients speech and we're continuing this program, and 400 Parkinson's speech, and then it's there. And supposing this in Play Store, this app is there so that you can use it for your patients, and also doctors can use it, the patients can use it, and then you have to speak into it, and then it's going to tell you whether you have a speech which is because of ALS or because of Parkinson's disease. But it's an ongoing project and the app is already created with Indian Institute of Science. So this again, we have cases with dropped head syndrome. What we can see many times, these are misdiagnosed as myasthenia gravis, inflammatory myositis, or even cervical spondylosis, and then patients have undergone surgeries. And these are our patients with advanced thing with feeding tubes and need a lot of palliative care. So we can have other lower motor neuron features. I see that I have only 9 more minutes to speak. The flail arm syndrome, where patients just have lower motor neuron features of the upper limbs. Either it starts proximally or distally and then spreads proximally and distally. And these patients do not have any upper motor neuron signs. But of course, on the evolution of the disease, you are going to develop upper motor neuron signs in these patients. But if it's profound, we may not find. And this tends to spread to all the body parts and then onto the respiratory muscles. So you can see this patient with severe proximal muscle weakness, and his lower limbs are fine, his distal muscles are good, and we call this as the flail arm syndrome. And a little more progression of this, you can see the proximal and the distal muscles are very, very weak. You look at the position of the arm, and this is called as the man and the barrel syndrome. His lower limbs are fine, his bulbar muscles are fine. And this 57-year-old man who has got such severe, they can't even lift their hand, and that's called as man and the barrel syndrome, which is one form of phenotype. And these patients will live very long. The prognosis is very good for these patients as compared to the ones with the bulbar weakness. So I'm going to straight away show this man who's got such severe weakness of the upper limbs, as you can see, and he hardly can lift, and it's because the flail arm syndrome. He's also got a foot drop on the left side, and you can see just concentrate on the upper limbs. His lower limbs are fairly good, his bulbar muscles are fairly good. Okay, so this is like a flail arm syndrome. Not to misdiagnose these patients. Many are treated like pure motor CIDPs. Also, I mean, they have received IVIGs and so much of immunomodulation. This patient had no bulbar symptoms. Carefully look at the tongue, there were fasciculations. And you can also look at the mini polymyoclonus as patients has. And also the fasciculations that you can see on the ultrasound. So if the distal and proximal muscles are involved, we also call them as the progressive muscular atrophy, a small group of patients. Just 3% of ALS patients have these. And again, the onset is in the upper limbs. and it spreads to involve both the upper limbs, and 1/3 will develop UMN features within 2 years of onset. So these are the patients who are difficult to diagnose. So look for fasciculations, look at the tongue for fasciculations, do ultrasound of the muscles which are unaffected, and you would find that they are fasciculations. And then you know that you can make a diagnosis of a motor neuron disease. So this is just another patient with proximal and distal wasting weakness. You can see this is called as the ape thumb deformity that you classically see. Apes do not have the abductor pollicis brevis, so that's the first muscle. So they cannot do opposition of the little finger. So that's one of the early signs that you see with motor neuron disease, the ape thumb deformity or the split hand syndrome, what we call. Again, just like upper limb, you can have lower limb involvement, which is sort of a foot drop. Okay, and that can be mistaken for a peripheral neuropathy, and then patients have had nerve biopsies, have had treatment for neuropathies, MRIs, even disc disease, because incidentally there might be a disc problem. So these patients have also important that you may not get the ALS case, which is so classical with upper motor neuron and lower motor neuron signs. And these patients usually have a very long survival, as you can see, as long as 96 months. So in fact, this patient was from Dubai, and he did not have a diagnosis for almost 2 years. He had a sural nerve biopsy. Can you see him walking? So he has a foot drop only on the right side, and he said he doesn't have anything else. And then you ask him closely, he said, yes, occasional fasciculations in the upper limbs. And what was important was you have to look for upper motor neuron signs. As you can see, there were fine twitches of the tongue muscles, which was missed. And this patient had received even IVIG for like a focal CIDP. And you can see the tongue fasciculations, which are there. Let me just go on, move. And you can see the reflexes. Reflexes was not looked carefully for this patient who had finger flexion also. So this patient had a pseudoneuritic form of ALS. So of course he was shattered when he told him, because he was all the time thinking that he had CIDP and is going to be potentially treated. But we had to really break the news to him and say that he is likely an evolving motor neuron disease. Look at the reflexes. Totally missed out by neurologists also. Of course, sometimes neurologists fear, they don't want to give the diagnosis away to the patient. So sometimes they're sent to NIMHANS so that the verdict is given by us. Of course, we are here to do that job also with a big team over there. So primary lateral sclerosis presents predominantly like a HSP, hereditary spastic paraparesis like picture. But usually within 3 to 4 years, they do evolve into ALS. So again, this is a group. I had 3 of my patients with primary lateral sclerosis picture, but they had tongue fasciculations, if you have to carefully see. They had upper limb reflexes, which are brisk, but because of the spasticity and knee pain, and they're all in their 60s, they went to the orthopedic surgeon and they had total knee replacement of both the joints. And 6 months into the illness, they had developed classical ALS. But of course, orthopedic surgeon is not going to look at the tongue or not going to do the reflexes. But because some pain and stiffness in the knee joints, and they have features of osteoarthritis, and they underwent the surgery. I mean, these are the sad things that have happened to the patients. But of course, if you chose to go to an orthopedic surgeon, he is looking at only joints and not at the muscles. So sometimes these patients can have bladder disturbances because of the severe spasticity, and we know that detrusor is also skeletal muscle. So let's not go into that. So very rare form, of course, I had a video which is not working. This is a Mills variant or a hemiplegic variant. We had only 2 patients of this type in the 3 decades of our experience. And patients with evolved like hemiplegia, one of these patients had multiple scans. And later on, when he developed progressive dysarthria, dysphagia, tongue fasciculations, they were referred to us. And of course, that was a hemiplegic variant of ALS. And of course, the video is not playing for whatever reason. I had tried in the morning. So ALS plus syndrome. So ALS can be a pure motor disease for all practical purposes, but you can have a plus syndrome where you can have movement disorders, supranuclear gaze palsies, autonomic nervous system, but they're all in the back burner. They are not the main manifestations. So I always tell, sometimes it's spasmodic dysphonia. Patients have gone to Dr. Ravi Yadav and he says, no, this is ALS. And they come to me, or some patients come to me and they're classical spasmodic dysphonias. And I have to tell, no, this is something to do with movement disorders, because at the end of 2 or 3 years, patient doesn't even have wasting weakness or dysphagia. It's only speech being altered. So there's an overlap. Of course, some of them they see, we see, but it's very important that we have our clinical acumen in hand, our experience. And as I said, high suspicion to diagnose a case of ALS, because we're going to give a diagnosis of a tragic disease to the patient. and to the caregivers. But nevertheless, we should do it in a very methodical way and breaking the news. I think I'm sure Dr. Professor Suvarna and Dr. Priya and all do that job for us in a very well way, but cognitive involvement can be there. So not to say that MND is not a multi-system disorder. So I'm not going to cover up on this. We know that 15% of patients with ALS, 30% of ALS with the ALS and 15% of patients with FTD have overlap symptoms. It could start with either one. We see patients with Parkinson's disease 2 years later, ALS picture, or vice versa. So ALS, FTD, PD, AD complex. So it could be either any of the combinations that you want. So the commonest one that we have seen is the ALS FTD overlap syndrome. So this is one of our patients who had, I know, can't make out as you see, but he was quite apathetic. He had a lot of cognitive disturbances, and you can see his hands. He had a classical ALS, and he also had a frontotemporal dementia. So I'm going to wind up. It's just 1 minute more for me. So you can have extremes of clinical phenotypes. So classically is the ALS with the upper motor neuron and lower motor neuron combination. Then you can have the progressive muscular atrophy, which is predominantly a lower motor neuron feature. And you can have the primary lateral sclerosis, which is predominantly the upper motor neuron. So it can also start with progressive bulbar palsy, and you can have the pseudobulbar palsy. Pseudobulbar palsy, I said emotional incontinence, excessive crying, unprovoked laughter. So they do go to the psychiatrist, but after some time they come back to us. Or the FTD. I've got 1 minute more, yeah. Or impaired cognition. So it could be young onset, it could be old onset, it could be aggressive disease, slowly progressive disease. So it, as I said, MND patients are not stereotyped patients. You have various manifestations and various way which they come to a general practitioner. So the phenotypes are spinal onset, bulbar onset, progressive muscular atrophy, primary lateral sclerosis, pseudoneuritic form of ALS, most of the time missed out. Nerve biopsies are being done. Patient is not examined thoroughly. Tongue is not looked for fasciculations. Ultrasound is not done for diffuse fasciculations. And then the hemiplegic variant, I said the flail arm, the flail leg syndrome. And these are the ones which usually confuse the clinician as to what the patient exactly has. If a patient comes with ALS, even a third-year MBBS student can diagnose, but the other ones. So just 30 seconds. And you know that you can have genetic forms of ALS, and 5 to 10% can be familial ALS. So this is what it is. And Dr. Gautam was here. I'm not sure if he's left. We have done about genetics for about 650 cases of ALS and with controls, and we have found a varied types of gene mutations. And I'm sure that he is going to cover up and he's going to speak when we talk about ALS. So it's not that ALS is 90% is sporadic, 10% is familial, and the genes that we encounter are much different. So we have this neuropalliative care for MND ALS, which was initiated, and the brain behind this is Dr. Priya from social work, and we're all part of it. And I'll conclude in 20 seconds. So MND ALS is a progressive motor neuron disease, affects more men than women, usually affects during 5th and 6th decades of life, several phenotypes and varied prognosis, bedside clinical diagnosis with no definitive biomarker, thorough clinical history and examination required. Listen to the patient as to what they tell. Don't be in a hurry to make a diagnosis. Everybody is a busy clinician. High degree of clinical suspicion. Simple investigations are enough to rule out symptomatic or overlap syndromes. And let's all wait eagerly with bated breath for a cure that is possibly narrowing. I'm sure that a lot of literature is coming up. And thanks for the patient listening, and thank you for the attention. Thank you so much.
Thank you so much, Dr. Nalini. In recognition and acknowledgement, I request Dr. Sina to give a certificate to Dr. Nalini.
This is the second one.
I now request Dr. BK Yamini to give her talk on navigating speech, communication, swallowing challenges in ALS and MND.
Good morning, everyone. On this day, which is the second international conference of the ALS MND, I would like to first thank Mr. Vasant Rao for inviting us to be part of this. Thank you, sir. And apart from this, I would like to thank three more people. One is Dr. S.R. Savitri, the ex-director of All India Institute of Speech and Hearing, Mysore, who has inspired me to take up instrumentation analysis of speech. The other person that I would like to thank is Dr. N. Shiv Shankar, ex-professor and head of Department of Speech Pathology and Audiology in NIMHANS. And the third person is Dr. A. Nalini, professor of neurology in NIMHANS. I thank each of them. So with this, I begin my talk, which says navigating speech, communication, and swallowing challenges in ALS. We've heard a lot about the different phenotypes of ALS. So we know that ALS invariably brings about a change in speech, which can in turn affect communication. So that's the first part. And later I'll be talking about the swallowing part. So is it not our responsibility to look at what the challenges related to speech and communication are that the ALS puts forth? So there's some study that we've done. So I'm going to talk about, just now Professor said that we are here because of the ALS. So I'm going to start with an illustration. Yes. So this is one of the patients who is a bulbar onset ALS, a 42-year-old person. And you can see that we generally use the ALS functional rating scale. And on this, you see that the speech score at baseline. So what we've done is we followed it up for a period of 1 year. So see the baseline score and then the follow-up scores, right? So the speech score initially is 2. So implying that it was intelligible with repeating. So that means if there was a problem in, he had dysarthry component, of course, but then if somebody asked, can you please repeat, he would repeat, and he would be very particular to repeat in such a way that the comprehensibility and the understandability of the listener, it would improve on the second time. So that way, so that is a score that he got. But then within 2 follow-ups, you saw that he had become, from a moderate dysarthria, he had become a person with anarthria. So there was a change in the speech. So that's the first challenge. So we know that it is not static, it is progressive, and it is relentlessly progressive. So we need to take up this as issue and look at the things. So now, why is salivation and swallow included here? Now, these are very important because an oral cavity which is filled with saliva cannot speak, and a drooling mouth cannot speak either. So it is important to control these aspects when we talk of dysarthria. So then let us look at the other challenges. We know that speech is not just, an output just from the oral cavity. It involves the entire subsystems, respiratory, phonatory, articulatory, resonatory, as well as the prosodic aspects. So now let us look at the respiratory subsystem. We just took 2 parameters and we measured the forced vital capacity as well as the maximum voluntary ventilation. So you can see at baseline, it was so low, it's less than 50%. So, and then what happens is, over time, we are unable to even establish his functional residual capacity of respiratory reserve. In other words, using this particular spirometry method. So the question is, when it is so low, what happens to speech? Will the speech be effective? We know that for speech, we need a certain breath support. Otherwise, it is not going to be effective communication. So there is a reduction. You see that it moved from 25.8, and in you could not test also, it reduced further. MVV came down. Now let us look at other structures, the anterior lip strength, which is very important. If you look at that, it was initially inadequate and later on subsequently became absent. So the articulatory system showed changes. Now here we are looking at, the non-speech movements as well as the speech movements. Now, when we look at the speech movements, it is important for us to produce the various sounds. When we talk of speech, it involves a lot of phonemes. And you have labial sounds like oo and e, which requires a protrusion retraction. So all this, now what if that is going to be affected? Is it going to be effectively produced? And you see that there is an inadequate structural change in the system, so what happens is the production is not possible. So it was inadequate, and you can see that later on, the movement of the lips was hardly there, or in other words, absent. Now, let us look at the rate of, when we look at two things. One is you calculate the rate, and secondly, you observe the movements, the range of movement, the rate of movement. So these things are very, very essential. And here you see that initially he had a rate of about, if you look at the graph on the right side, right top, so you can see that he could produce about 4, and then it came down to 0. So it means there is hardly any movement, no production of these sounds. So that means there is a modification of the phoneme oo and e to almost a ah. So what happens to communication? There is a breakdown. Dysarthria becomes severe. So that. Now let us look at another bilabial sound that we all look at. And just like how didactokinesis is done for another system, we're looking at speech didactokinesis. So here we look at rapid alternatory production of the syllable pa. So here initially it was 3, and then it came down to 1. Now this is not that it was accurate. It was a distorted production of an utterance. So previously we saw vowels were getting distorted. Now I know that even the consonant part is also can get distorted. Now let us look at more sounds. Now, how are these phonemes produced at the articulatory level? We have the lingual sounds, right? We have anterior lingual, posterior lingual sounds, all these come into the picture. So now let us look at the baseline assessment for rate of lingual movement, range of lingual movement. It was restricted. We look at all kinds, protrusion, retraction, lateral movements, up and down sweeps, everything. So that was restricted and later on absent. So that means we had the structurally, he was showing atrophy, and then initial movements were there, and subsequently now the tongue was just resting on the floor of the mouth. So there was an absent movement. Now we look at some other things like the soft palate movement. Palatal reflex is one more, as she said, madam said earlier. You get an exaggerated reflex, but no movement for a production of a phoneme, the ah. Right, the soft palate. So that can also happen, resulting in hypernasality. So here, if you see that there is a velocipharyngeal closure initially, which was adequate, and slowly it became absent. So you can expect that the resonance is affected. So it is not oral resonance anymore. It becomes a nasal resonance. So it is almost, someone speaking like a nasal twang. So you can see the progression of dysarthria. Now, and what about the breath pressure? We know that to produce the phonemes, you need enough breath pressure within the oral cavity. So that test is also done. So you can see that it was initially inadequate and later on absent. So you have a labial weakness. You have, the jaw muscles are weak. He's unable to bring about a closure. He will not be able to build up the pressure. Now, there are plenty of pressure consonants. All the stop consonants are all pressure consonants. So you need to build up air, and then you can produce. For example, if I have to say pa, I need to bring about a closure, and then I release the air pressure. So there is that is required. So these are all the changes that one needs to extrapolate as and when we observe the structural changes and looking at the functions. So then we also tested, again, didactokinesis, we have another test. So here we had the TER, which is for the anterior part of the lingual, and the KER for the posterior part of the lingual. So you can see a reduction in the rate that was evident. So move from 2 to almost 0.5. Well, how do you measure even 0.5? So we need to do some kind of an instrumental analysis and say, okay, so he did not complete an utterance within 1 second. So such things, and there was a distortion of the articulation. So now you can see that the challenges are there at respiratory, resonatory, and at articulatory level. When I said articulatory level previously, I was still talking about, isolated CV combinations. Now, what about a combination of sounds that we take? So if a DDK for a per Turk, it is a combination of sounds. So it has a labial, it has a lingual sound. So you can see that there is a decline from 2.5 to almost 0.5. So that means By the time it is a 3-syllable utterance, by the time he just says a portion of that syllable, it is already half a second. So just imagine we have what is the speech rate? Generally, we speak at the rate of 150 to 200 words people can speak. Now, if someone is speaking at such a slower rate, then what happens? Dysarthria is severe. So on. So then we look at another aspect, which is the phonation duration. We all know that it's not just the respiratory, the coordination of the respiratory and the laryngeal system. Often what happens, there is going to be some kind of a weakness at the level of the vocal folds. There's going to be abductor issues. So because of that abductor weakness, you can have reduced phonation duration. So a combination of these, your respiratory, phonatory, and so it can bring down the phonation duration from 10 to it has brought it down from 10 to almost 4 seconds. So just imagine in each of the subsystems of speech, there is a change in a period of 1 year. So you can expect, that the person is almost becoming an anarthric. So given that we have, we can also use, the perceptual methods and the objective methods of measurement. There are many other objective, I would just like to mention here that there are many other objective assessment methods. What we have used is a electromagnetic articulography. This is basically purely on the research side. Otherwise, clinically, it is different, and this is for research. It is very tedious to conduct research, wherein sensors, as you can see, are placed on the lips, jaw, as well as on the tongue to record the kinematics of speech. So that means we are looking at distance traveled, acceleration, velocity, all these kinematic parameters related to speech. So a photograph below, on the left side, is you can see the atrophic tongue. So sensors are still placed on that. We are trying to see what is the phoneme that he can produce, what is the range of movement that he can produce, and so forth. So we can do more objective analysis for this. Now, this is the result of that. As you can see on the left side of the screen, you see a kind of wave, which is, there are so many cycles that you see. I have circled it also. So you can see so many cycles. This is in a healthy control. And the number of cycles are less in a ALS. So that means the protrusion retraction movement of the tongue is much less in the ALS than in a healthy control. So that means, the rate is going to be affected. So we have objective methods also of knowing how the rate of articulatory movements are. Today, we are also talking about machine learning. Yes, I thank Dr. Nalini as well as Dr. Ravi Yadav for the collaboration that has really, we've come out with almost 11 conference full-length papers which are reviewed, which are review papers, peer-reviewed papers. And this is one thing that I want to talk about. Now, I spoke about acoustic analysis from one dimension. Now here I'm talking about acoustic analysis of speech from a different dimension. So here you can read that source and vocal tract. So that means this is based on the acoustic theory of speech production, that source is filtered to produce speech. Gunnar Fans, popular model that is used for this. So here what happens, so algorithms are used which segregate both the source as well as the filter. And then, what does it say? And so what I'm trying to say here is that machine learning analysis is available today, and a lot of data needs to be fed in so that you can segregate, and say, okay, there is, the person has dysarthria or it's a normal speech. So that is the thing. So there's more, it's more advanced, and the app is available. It's called as the Neuro Companion app, which is available on Google Play, and you can download it, and you can give us a feedback. You can please write to Dr. Nalini or write to me after using that app. That is there, and it is there's a lot more development that needs to be done, because speech, as said, is multidimensional. Are you looking at subsystems of speech? Are you looking at acoustics of speech? Are you looking at articulatory aspects of speech? And are you collecting speech data in the presence of a background noise? There are a lot of issues when we talk of speech as well as its diagnosis. So coming to this, now we know that challenges are there, and challenges can be recorded. So what happens when the challenges are in speech are there? We know speech is a verbal communication mode, is a mode of verbal communication. So once a person stops speaking and is just communicating only with the syllable, what the phoneme are, the others stop communicating too. There's a communication breakdown that happens. Even the family members kind of back out, the friends back out. So they say, okay, we don't understand what you speak. We do not know what to do, all this. So in other words, the communication breakdown can occur due to two reasons. One is the speech is being impaired. So in other words, there's a dysarthria, anarthria component. And the second reason is, as it is pointed out, there are variants. That is, you can have FTD along with ALS, or you can have, Alzheimer's component with ALS. So the language can be affected due to cognitive issues in an ALS patient. And hence, again, there can be a communication breakdown. I'm not touching upon the second part. I'm just going ahead further. So given these challenges, we have to look at whom we are talking to, addressing these issues. We have to break this bad news to them that yes, there is no they come back, they come to us thinking, oh, okay, speech is different from limbs. Very often it happens. So we need to convince them that the entire human system is affected. The motor system is affected. And where there is, you have UMN signs, element signs, just like how you have in the limbs, you have signs even in the oromotor, oculomotor area affecting speech. So it is important to educate the family as well as the person with ALS. How and it all depends upon a lot of clinical experience, a lot of feedback from them can also give us how to approach these persons and convey the information. So as a result of all these challenges, what is the first thing that we need to give is a supportive communication strategy. So giving them the time to speak. So we saw that the phoneme is taking a long time. There's a lot of time that is taken for to produce each phoneme. The rate is reducing. So that means to speak even a sentence, instead of taking a fraction of a second, he's going to take almost 2 to 3 seconds. Do we have the time to listen? No. So that means that is what we need to educate the family. You need to give time. You need to listen to that person and allow him to communicate whatever he wants, like how he was doing previously. And then you need to have patience, empathy. So that is how you educate and involve the family. So what are the intervention strategies? So one of them is, we know that if any kind of exercise physiology is going to aggravate the fasciculation, any kind of exercise physiology is going to increase the weakness, they're going to develop fatigue, just like in the limb area, so also in the vocal area. So that means I'm looking for safe speech breathing. So what do you mean by speech breathing? We know that we need breath support to speak, and breathing for speech is definitely different from breathing for life. So we got to educate them how they need to use this as a compensatory strategy. Speak just right, take in those breaths, and then continue to speak. Give the pauses in between. So otherwise people think if you have to speak, you just have to, it's a continuous stream of sounds without a pause. If you don't speak like that, it is not speech. So that is what. So unless we tell this, they do not understand what we talk of pauses in speech. Yes. So then we have strategies to maintain the precision. We tell them as much as possible, try to speak as precisely as possible. We're all born here, and in our vernacular medium, we know how the phonemes are produced, anterior to posterior. We have it in our languages. So you just educate them on how each of the sound, Pabama being labial, Tadana being anterior lingual, Tadana being mid-palatal, and Kaganga being posterior. So when you educate them on how the phonemes are produced, they tend to understand. And then, it is even better. So they try to, go slow, make it precise, and they try to communicate excessively. Efficiently. So, and if hypernasality is an issue, then what happens? Very often we may have to start using alternate modes of communication. A total nasal twang, the other person doesn't understand. So overall, the best efficiency in speech output needs to be maintained. They can talk to a speech pathologist who will guide them on these strategies as and when there are changes in the pattern of speech. And very importantly, energy conservation is important. There are a lot of people, there are singers who come to us. Can I continue singing? We say no. we were practicing, 3 to 4 hours. I say, no, you cannot do that. You need to conserve the energy. You cannot fatigue your system. Yeah, because in singing, it is a combination again. You're using your respiratory reserve, you're looking at the laryngeal system, the speech and the singing is so much coordinated. The same systems, similar systems are being used. And added, there is going to be what we call as the increased breath support that is required. So everywhere you can see that there is a lot of what do you call as stress on the system, which needs to be avoided and so forth. So counseling them is the first step. Now we know that, let me tell you that patients are our best, teachers. They know how to communicate. They realize that they're not able to speak. They automatically have a paper and pen. They use the mobile. We don't have to train them. It is their cognition. It's a normal cognition person who uses, any other more, but encourage that. So as clinicians, it's important for us to encourage this. Otherwise, they think that speech is ultimate. So it is important for us to emphasize that speech is not ultimate. So then, if they can afford, you have tech devices, low tech and high tech devices, and that can be used for communication. You can suggest these and hybrid mode. So some of them will be using speech as well as, alternate mode. Maybe they want to communicate at length. He doesn't have enough respiratory support. So then what happens? He may have to, write more and then communicate. So and little words. So a combination of these would be required. Environmental modifications is the next one. It's so quiet. And even if I just whisper, you will be able to hear. But what in their case? We are always speaking in the presence of TV noise. There's a construction noise around. There's a market noise. So there's always a background noise. So it's important that, that we pay full attention to the speaker or, take them to a place where the background noise is less. At home, make it convenient so that there is reduced background noise. And when they speak, because we know that hoarseness, weakness of voice quality are the characteristics, and reduced loudness can also be there. And so that is why we need to, ensure environmental adaptations and so forth. Then seating. It is like, if we don't look at the speaker, we do not get 70% of the information, whether we are hearing impaired or not. Even otherwise, looking at the speaker gives us a lot of information. So there must be enough lighting on their face so that there's successful communication. Now, voice banking is not a technique, but it is suggested to them, and wherein individuals will record and preserve when the problem is mild, or when they do not have, the bulbar features yet. So they can record their voices and keep it. And later on, we know that it's a relentless progressive condition. They can use their voice, for communicating. So that is also suggested. That is recent. Some of them accept, some of them don't accept. Most of them, I would say, no. So that is on one side. So we need to go through these ones. We know the challenges are there. We need to go through. Yes. So next is the swallowing. So what are the challenges in swallowing? We're looking here at oropharyngeal dysphagia. So as mentioned earlier also, the history related to dysphagia is very, very important. So we know what happens is there's going to be jaw droop, there's a tongue atrophy, there's a dysfunction of the closure of the soft palate, the larynx is going to be affected, and diaphragm function. So all these contributing to affecting swallow in various phases. The oral phase is going to be affected, as well as the pharyngeal phase is also going to be affected. So here it is important for us to assess these so that we maintain the nutrition, hydration, as well as the medication for the individual. So I come back and use the scale again, because now my focus is again on swallow. So what happened to the salivation? What happened to the swallow? The swallow was initially better. That was at 3. So which means that just brought the scale here. So it was 3 where, eating, it is early eating problems and occasional choking. And it came down to 2, which means dietary consistency changes. So you can see that with advancement, there is a change. So dysphagia also increases, the severity increases. So then, So now what do? We do a clinical bedside swallow examination. You have various protocols. You have AL swallow protocol or an informal assessment. We use, look at the variety of food that we eat. So we need to assess, all the varieties, whether it is pureed or a moist food or a soft bite or easy to chew food, or do we need to assess, the pudding, the custard type, to a thinner, a little more, thickened liquid like a juice ordinary, to a thin liquid, which is water. So we have to try all this along with medication. So an assessment is done. So the instrumental assessments that are available are the video fluoroscopy as well as the fiber optic endoscopy for swallow. So in video fluoroscopy, you get information on both oral and pharyngeal phases. In fiber optic, you get more pharyngeal phase details. Now, what did we do? We had the electromagnetic articulograph. So we did a study on mastication in ALS group. So here what we did, as I showed you earlier, where the sensors were placed, instead of assessing speech, we were assessing mastication. So here what we had about 4 spinal onset and 5 healthy controls. And we looked at the temporal kinematic features, wherein we looked at the number of cycles, the cycles per second, total distance traveled, average speed, velocity, acceleration, and so forth. And what were the results was that the duration, as you can see, was longer for the ALS when compared to the healthy control. So that means time, you need to give time to eat. This is a beautiful poster put outside, which talks about the management of dysphagia. I request all of you to please have a look at it. Yes. So time is very, very important. You cannot hurry and tell them, okay, there is a taxi that has, Ola taxi has come. We got to go. You got to finish drinking water in fraction of a second. No, it is impossible. So you need to give them time to do this, to eat and drink. So in kinematic features, we have, as I said earlier, and we found that the lip aperture is one factor that is affected more in them. So that means the amount of movements that you make during mastication is limited in the ALS when compared to the healthy control group. So that means with the study, we say mastication is affected, oral phase is affected. So when I say that, okay, I need to look at diet, wherein, okay, if he's going to take that much of time to masticate, can I just keep giving him and make him eat for 2 hours? Or do I make a change in the diet consistency? Something like that. So all these changes have to be thought of and communicated to them. So in other words, once we know the challenges of dysphagia, we look at the management. So what are the management strategies? We have the postural strategies, we have the bolus control, volitional airway, diet modification, and prosthetic devices. Last one, prosthetic devices, palatal lift and tracheostomy is the last. And most of the time it is just not done at all. And I have not seen anyone with that. So postural, it's important to sit upright, head tilted slightly down and never upward. Why? Because we are changing the physiology. If you look upward, when we choke, when the healthy control chokes, they say look up. That is fine because your muscles can control that input. The physiology that works at that time is very different when compared to a ALS group. So that is why we say when they choke, do not ask them to lift their head. So that is one. Bolus control. So what is the quantum of, what is the quantity of intake? That is per intake. Right? Should they take 1 teaspoon full loaded completely? Wow, this noodles is very nice. Let me roll it up in the fork and have a mouthful. Or should I say, just take a few strangles and then you put that, masticate enough, swallow safely, and then look for, they need to have a feedback. Let me tell you, if they don't have cognitive issues, they are fantastic. They follow all these strategies. They wait, they look, and we all clear the oral cavity. So these strategies have to be informed to them step by step so that they realize, only then they will follow. Otherwise, we tell them, okay, small quantities, they want that. I just need another minute. Thank you. Yeah. The next step, the quantity of, that goes into the mouth per intake is very, very essential. So that means you give them longer time. Then volitional airway protection. We know that this is a very, very important issue. We can do the tests and we can actually show them that at the moment of swallow, there is a fraction of a second when there is an airway closure. We know that there is going to be closure at the 3 different levels, right? So you have the epiglottis, the false vocal folds, as well as the true vocal folds. Everything needs to be really tight in order to not to allow the bolus to just, just penetrate or aspirate. So that is why volitional airway protection has to, this is an education. We need to tell them how to go slow, how to control their breathing, and how to swallow. That's an important point. Then the diet modifications, as we said, if they are unable to chew a hard rusk, it's important for them to go to a softer diet. Or if they are unable to, drink, too much, if they are unable to drink water, they need to use a thickener and swallow, and so forth. So with this, I conclude, and I thank you all for your patient hearing. I thank you. Thanks very much.
Thank you, Dr. Yamini. I now request Dr. Saraswati to please give her a certificate of acknowledgement and recognition. Thank you. We'll now take a tea break for 15 minutes, and then we'll return back. Thank you.
ನಾಗರಾಜ್ ಅಣ್ಣ
ಬೇಡ 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 ಬೇಡ.
Hi. I request each one to please start taking your seats. Welcome back. I now request Dr. Rajni Bhatt to give her talk. She's going to speak on respiratory involvement and symptoms management in MND.
Good afternoon, everyone, and welcome back from that coffee break. I would like to thank the Dr. Shama Narang Foundation and Vasant Rao sir for the invitation to join the discussions today. It's truly wonderful to see clinicians, researchers, patients, caregivers, everyone coming together to share their learnings and see how we may all work together. And, you know, I know that the theme of the conference this time is breaking barriers in MND. I think the most important barrier that we are breaking is to break out of our silos and learn how to work together. Not as a neurologist, a pulmonologist, a speech and swallow therapist, or a physiotherapist, or a respiratory therapist. Each of us has our areas of expertise, and each of us has something that we have studied deeply or spent time on, but there are overlaps. And I think the more time we spend with our patients, we realize that pooling our knowledge and resources together is actually how we'll get to achieve the best quality of life improvement that we might for our patients. So I'm going to try and address some of the respiratory issues that we face, our patients face, and see how we can use that multidisciplinary approach. I will bring my pulmonologist hat, and I will also bring my palliative medicine physician's hat here. I also want to acknowledge someone else who's in the audience today who's inspired me greatly to take up neuropalliative care as an additional area of interest. So Dr. Roop Gorsani, thank you so much for all your gentle nudging for almost the last 8 or 9 years now to learn how to integrate all the learnings from different fields and apply that in our everyday practice. So thank you. I'll be speaking a little bit about neuromuscular respiratory failure. You heard in Professor Nalini's talk about how that's the final common pathway for most patients. So the symptoms and signs broadly, how do we test for respiratory involvement? We'll speak more about breathlessness and ways in which we can address breathlessness. And that would involve devices, that would involve medications, cough and secretions, things like tracheostomy and feeding gastrostomies, what to do when patients have acute emergencies, how do we address care in ICUs, and advanced care planning. Some of this may spill over, and you will see some issues being addressed in my in my time, as well as when Dr. Gorsahani speaks about palliative care in MND. But I think we will be speaking to different aspects, and it only helps to reinforce what we need to bring to the table for our patients. So neuromuscular respiratory failure in patients with motor neuron disease is usually a gradual onset, and it's very subtle, but very rarely it can be the presenting symptom. So for patients, you know, again, going back to the first lecture about the different phenotypes of motor neuron disease, and you spoke about, you know, we heard about how the diagnosis could be missed very often until things are progressing. So we do sometimes see patients coming into the emergency room, getting intubated for acute respiratory failure. And it's only when you start figuring out that you're trying to wean them that there's a difficulty that you realize that there is an underlying neuromuscular disorder. And that's when the diagnosis of motor neuron disease may be unmasked. The perception of breathlessness in patients is often blunted. And it's less than 20% of patients who, without a diagnosis of motor neuron disease, will just come to you with, I am breathless. I don't know if any of you have heard the story of the frog who got cooked. There's this old tale about a frog that was swimming in a vat of what he thought was like a little pond, but was actually a vessel that he was being cooked in. And it was swimming around happily, and it thought, the water's getting a little warm, I should get out. And then it was like, I'll wait a little bit because the water still feels nice. I'm not that tired. I'm okay. I'm not that breathless. I'm okay. And then the water gets hotter and hotter and hotter. And you've been ignoring your symptoms, or you've been managing, you've just been adjusting your movement. So instead of being able to swim as actively as before, you've decreased the intensity of your movements. You've decreased the movement in order to decrease the sensation of fatigue, until suddenly you realize the water is so hot that you can't jump out. And that's when you're cooked. So that's something that happens to patients who have this gradually progressing breathlessness. They often complain of fatigue more than breathlessness. So the complaints that they'll come with will be very vague and generic. So that's why they may not come to a pulmonologist. They may be coming to their regular primary care physician and saying, I'm not sleeping well, I have headaches in the morning, I'm just more tired. And the one distinct factor that happens is that there is breathlessness when they are supine. So very often when you have patients with breathlessness, when they are supine, when they're lying down, they'll get the workup for all cardiac illnesses because they've got orthopnea. But one forgets to check their respiratory function. One forgets to look for neuromuscular disorders. And that's one of the things. The excess secretions can be a dead giveaway. Weaker cough, weaker sneeze, change in voice. My voice isn't as strong as it was. Choking spells can happen. And sometimes panic attacks, waking up in the night feeling like your throat is closing down. And weight loss. Weight loss, again, is one of those very subtle things. It's actually related to the breathlessness. You heard earlier about how swallowing is such an important part. And then since eating starts taking longer and longer, you're consuming less and less along with the higher metabolic rate. So there's weight loss, which is subtle. So these are all the subtle features that we find. Other than that one, presentation of acute respiratory failure, everything else seems far more subtle. But if you're alert to the possibility, then you start looking for the signs of respiratory failure sooner, monitoring for it, testing for it. And how do we test for it? Spirometry is how it was done traditionally. And in this, we look for a drop in the forced vital capacity. So I just want you all to do a little exercise along with me to understand this. So I'm going to keep my hand here. This is you breathing in and out, just normal. Okay. And then when I say take a deep breath, go all the way up to the top. And then all the way out. And then all the way up again. And then come down to your baseline, right? So the all the way up to the top, all the way down when you go fast, that's your forced vital capacity. All the way up to the top of my lungs, all the way down to the bottom of my lungs. Get it all out fast, forced vital capacity. Person who's got some muscle weakness may not be able to do a good forced vital capacity. But they can do a slow vital capacity where you give them the time to go all the way up to the top and then do a slow exhale out as much as you can. So these are the two things that we like to look at, the forced vital capacity and the slow vital capacity. Arterial blood gases are useful because they can tell us early on if the breathing is getting impaired, if there's hypoventilation, especially at night. Our breathing muscles are primarily our diaphragm for breathing in. Accessory muscles that we use for inspiration are our scalenes, the sternocleidomastoid. All of these are our accessory muscles that we use for breathing in. Exhalation is usually just a passive thing, but otherwise we use our abdominals to exhale. So these are the muscles that are involved. When we lie down, the only muscle that is doing breathing is the diaphragm. So when you are lying down and you are asleep, your accessory muscles are not engaged. So you might be able to compensate for your breathlessness and take deep enough breaths while you're awake, but when you're asleep, it's only the diaphragm. So if there's diaphragm weakness, that's when the hypoventilation will happen at night and you'll have a higher carbon dioxide level in the morning. Another thing that's measured is the negative inspiratory pressure, a maximum inspiratory pressure effort, or a sniff, which is measured in the nostril. In India, our access to spirometry itself is difficult. So access to going to arterial blood gas, sniff, and all of that becomes even more challenging. In city centers, tertiary care centers, we have access to these measurements. So it should be used if we have access to this for our patients. An overnight oximetry is another way of checking to see if there's nocturnal desaturation. Patients may have sleep disordered breathing, which is obstructive sleep apnea or central sleep apneas, in addition to their motor neuron disease. So it's always good to do overnight oximetry, or if you can, a full sleep study. One very simple measure, which would be very useful, even if you don't have a full spirometry, is a peak cough flow. So peak flow meters are something that you can keep in, that all pulmonologists have in their outpatient. It's part of our vital signs for anyone with an airway disease. And it's just blowing into a machine and you do a best of 3 effort. Now, for some patients, especially who have difficulty with creating a seal for the spirometry, you can use a face mask with a peak flow meter and hold the mask with a good seal around the nose and mouth, because they're not able to hold the mouthpiece with their lips tightly, and check the peak cough flow. The peak cough flow is something that tells us if you are able to generate the force required to expel secretions or anything that's entering your airway that shouldn't be there. And the cutoff value that we're looking at that for safety is more than 160 liters per minute. Most of us in this room will be about 350, 380, right up to 600 or something. So what we normally measure for airway disease is a peak expiratory flow, where I'm doing, and in a peak cough flow, I'm making them cough with that. So it's far more forceful. A cough is much more forceful than a regular expiration, even if it is forceful. Chest x-rays may be required depending on your clinical examination, and echo, again, depending on comorbidities, or if there's some signs that are telling me that this patient may have pulmonary hypertension and other features. A 6-minute walk test is something that's part of the armamentarium of pulmonologists, and it wasn't used as much in motor neuron disease earlier, but now is also being used in motor neuron disease because it gives us an idea of 2 things. One is how much the patient is able to do, and also how well the lungs are keeping up with it. And there are now studies looking at seeing if it correlates along with the other scores that you use to observe the progression in ALS. So is the 6-minute walk distance a marker that we can use? Again, this becomes an easy marker even in a low resource setting. So where you don't have access to spirometries and arterial blood gases, and I want to understand how this patient is doing in terms of their breathing and their functioning, a 6-minute walk distance becomes a good measure for me. And it's good to reassess this every quarter. When I start seeing a drop, then I start asking them much more closely for symptoms, and then they follow up sooner, because these drops are what is going to tell me if there is an intervention that is called for. What would that intervention be? That intervention could be non-invasive ventilation, could be whether they need oxygen at night. So let's try and understand breathlessness a little bit better. We did one little exercise, which was understanding what our normal tidal ventilation is, what it is to go all the way up to the top, all the way down to the bottom. So now let's try breathing much less at the bottom side, and you'll see what you might get a sense of what the experience of breathlessness is for a patient. So just take a deep breath in and out. We'll just take a few quiet breaths in and out, in and out. In, blow all the way out. Only 1/3 in, 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 all the way out. And now breathe normal. How did that feel? I didn't like it. And I was just standing in one place, but it was an effort. Now imagine if you're breathing at that bottom end over there, and you're walking, you're talking, you're eating, something's gone into your airway and you're trying to cough and I'm not able to generate that, right? That's the feeling that the patient is experiencing. And it's not, we experience breathlessness when I have to run for a bus, I'm late for a lecture, something, right? And it's immediately rewarded by my extra effort. I will run up the stairs, my body's feeling breathless, I'll pause, I'll take a few deep breaths, and I feel okay again. this patient is trying harder all the time and not getting rewarded for the extra effort and still feeling breathless. So what it does, we've started understanding what breathlessness does to our minds, to our bodies, to everything, to our entire being, much more in the last 20 years or so. So it creates all these emotions. There's fear, there's anxiety, there's, oh my God, I'm going to get breathless. I need to go to the bathroom. I am going to get breathless. So I'm already anxious about going to the bathroom. There's a lot of sense of loss of self. There are people who've had very active lives. There are people who've had lives where they use their voice a lot. And with losing their breath, they are losing their voice. They are losing their professional sense of self. They're losing a lot over here. There's also certain other changes that are happening, just absolutely correlated pathophysiologically. There's cardiovascular changes that are happening. And all the other factors as well play a role on our experience of breathlessness. Your age, your nutritional status, there is so much that plays a role in our experience of breathlessness. Some of the most illuminating work in understanding how we may work with patients with breathlessness and creating a simple education model that works for healthcare practitioners, caregivers, and patients has come out of the Cambridge Breathlessness Intervention Service. And this is the model that was created by Professor Anaspatis and Dr. Sarah Booth. This is the breathing, thinking, functioning model. And even though this was designed primarily for patients with chronic respiratory disease, it has a great application across all specialties for anyone experiencing breathlessness. So this looks at how we experience breathlessness in terms of when I am breathless, is my adaptation to the breathlessness a good form of breathing which helps me to conserve energy, or am I actually using up more energy? What are the thoughts that are in my head that are worsening the experience of breathlessness? So if the last time I was breathless, I was rushed to the hospital and I got intubated and I got, I had people jumping on me. I couldn't speak. I wasn't able to speak. And all of this happened to me. That's the experience. The next time I have breathlessness, oh my God, I'm going to go down that pathway. How am I going to stop that cycle of thought and say, no, 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 I know how to handle this. And functioning, as you get breathless, you move less. As you move less, your muscles get more deconditioned, and then you get more isolated. So we need to address each of these aspects of breathing, thinking, and functioning and break those vicious cycles in order to make the patient get the tools they need for mastery of breathlessness to lead a more active life. So breathlessness isn't going to go away. It's just we learn how to deal with it better and still continue to fulfill our goals in life, personal or professional. These are just simple images of ways in which they can keep active and know that they have a place, a safe position that they can go to in order to do a little recovery and energy conservation. So these are the kind of images that I hand out to patients and their caregivers, saying that caregiver can say that if they see their loved one looking a little breathless, immediately see, oh, why don't you just turn around? Because I told you that the perception of breathlessness is blunted. So sometimes they're breathing harder, but they're not even aware. And someone else can say, just move your position a little bit like this, and it might be a little easier. So this is your awareness and the caregiver's awareness that can help. There's simple devices that help. A handheld fan decreases the sensation of breathlessness. So blowing air on the face, stimulate the trigeminal area, decreases that sense of anticipatory breathlessness. It actually slows down our breathing and you're much better controlled with your breathing. So a moist cloth on the face and a handheld fan just about 15-20 centimeters away from your face. This is basically what the rushing to the window when you have heart failure is all about. I want fresh air on my face. This is what when anyone falls down in a faint, then you fan them with a paper. That's what it is. You're trying to give them the sensation of air on their face. It decreases the sensation of breathlessness. Using devices to conserve energy for your mobility, again, will help in the decreasing the sensation of breathlessness. And keeping a step counter, just some motivation that I want to keep myself moving. So these are ways in which we say, don't let your breathlessness limit your activity and to keep it going and slowly work at it. So it's back and forth, whether we are trying to increase the ability to do certain functions or reduce symptoms. The same action for breathlessness, the same rehabilitation, the same physiotherapy will help us in symptom control, and will help us in increasing or improving function. It's just the goal changes. So when a patient is in a slump, is in an exacerbation of any kind, has an infection, is feeling weaker, at that time our goal is symptom control. So you don't push them too hard. It's a submaximal effort. And when they are feeling well, maybe at that time you can work at building up and improving function at that time. Let's talk a little bit about oxygen and hypercarbia, hypoxia and hypercarbia. Overnight oximetry, as I said, is one important tool to help us understand, because that can tell us early on, even before the patient reports that they are actually breathless or they have retained secretions, that this patient might benefit from oxygen at night. Doing a sleep study, doing an arterial blood gas can also tell us if this patient might benefit from non-invasive ventilation at night. For patients with motor neuron disease, we prefer to use BiPAP and not CPAP. So that's a subtle difference. I don't want to go into the details of it, but BiPAP is better because these patients need, one, the positive airway pressure to splint and keep those lower portions, atelectatic portions, open. And they also need the assist of a little higher pressure on inspiration so that with the smallest effort, they're able to draw in breath. There's multiple devices that we can use for delivering oxygen. There can be the nasal cannula, there can be face masks, and then there's the high flow nasal cannula, which we use sometimes in hospitals and intensive cares as well as in the wards. And then there's the non-invasive ventilation. Let's look a little bit at cough. It's a protective reflex. In my day-to-day practice as a pulmonologist, I am trying to get rid of cough. It's the third most common complaint in the world. So I see a lot of cough every day. But with my motor neuron disease patients, with my neuromuscular disease patients, I'm trying to make sure that they stay coughing. So it's the reverse problem here. In our pulmonary patients, we're trying to suppress their cough, and here we're trying to assist them because the cough is one of the most important protective reflexes that we have. There's 3 phases. One is taking in that deep breath. The next is a compression with a closed glottis where I'm building up pressure in my chest. And then there's this forceful expiration where I'm expelling out anything that's in my airway that doesn't belong. And with motor neuron disease, all of these 3 can be involved. It's important to observe your patient's coughing and monitor that peak cough flow. It's an easy one to monitor. So I think compared to spirometry, that is a much easier one to monitor. And it tells us a lot about when we might need to intervene for patients. What about secretions? We spoke about sialuria, increased saliva, thick tenacious saliva secretions. So it's important that we understand the quality of those secretions. Look at all the usual things, onset provoking, palliating things, understanding the patient's values about what to do with that secretions. So when the secretions become too much to handle, that's when we have to think about, are they able to swallow? If they're not, are they at risk for aspiration? If the patient's, the character of the secretions is changing, we have to look for infections and also look for any other illnesses that may be there, whether it's heart failure or any hemoptysis or any infection, anything like that. In order to help us managing secretions, we use a manual assisted cough. We sometimes use a mechanical insufflation, exsufflation device, which is basically giving the patient the extra breath. So what's happening here is my patient's not able to take a deep enough breath. A mechanical insufflation, exsufflation device will be a mask with which I can help the patient take in 1, 2, 3 larger breath and then be able to use the cough in order to expel secretions. This could also be manually assisted with a little pressure on the abdominal muscles to help them cough out the secretions. There's chest physiotherapy and postural drainage. There's percussion that's done with a vibration vest, and that's for peripheral mobilization of secretions. Not as important in our patients with motor neuron disease as in respiratory, but definitely some use in helping in mobilizing sticky secretions. Mucolytics is an early stage disease. When patients are at an advanced stage, we want to try and give them antimuscarinics only if absolutely necessary for the patient's discomfort. If it's just about a noisy upper airway sound which is bothering caregivers, but the patient is comfortable, I don't want to give any medication for that. Sometimes we have to do bronchoscopies to do clearance of mucus plugs, because there can be lobar collapses or one side collapses. And then that's something that's very easily fixable. So these are the devices that are available. There's cough assist devices. There's lung volume recruitment bags. Harder to get in India. We sometimes just have our respiratory therapists use an ambu bag. Not the best, because this one actually has a one-way valve to be able to stack breaths. But it is a substitute that we can use at times. Let's look at non-invasive ventilation. There's many different interfaces that are available. It is uncomfortable. I would ask if anybody has access at any time, if there's any device people out here outside, just see what happens when you just hold the mask close to your face when they turn the device on. And think how uncomfortable that is. I was telling you that one of the things about breathlessness is you want to feel air on your face, but you also don't want to feel claustrophobic. So this mask, which blows air tightly at your face, can be uncomfortable. So it's important that we try to find the right interface which fits the patient well and is comfortable enough for the patient to use. So there's nasal masks, there's full face masks which cover the nose and mouth, there's nasal pillows, there's a full face mask which then avoids any kind of pressure sores on the bridge of the nose, because sometimes patients can develop pressure sores on the bridge of their nose. It's a very painful condition. And I've also shown a little silicone pad that can be put on the nose to prevent that. So always be careful that when I'm giving something to help, I'm also looking at not causing any more pain and discomfort for the patient. A word about aspiration, pneumonia, and PEG. When do we think of a PEG? And what is this big problem with aspiration pneumonia? The problem is that patients have difficulty handling their secretions because of their bulbar symptoms. They're not able to swallow. The saliva may be quite thick and tenacious. They're not drinking enough water because water is hard to swallow. So they're dehydrated, thick secretions. Because of that, the mouth is drier. The oral flora is worse now. And then they're aspirating that. So this leads to worse infections. The most common bug is Pseudomonas. So the first thing is that we always try to make sure that patients are positioned well at home. They know in what position they should rest and sleep. Caregivers are aware of that. But you might still have dysphagia ongoing. Feeding is taking longer. As you said, it could take about an hour or more to feed, and they start losing weight. So with malnutrition, your infections are going to rise. So this is when, and there's loss of muscle strength. So you really want to try and plan for the feeding, gastrostomy, and the PEG before they start losing too much weight. There are certain guidelines that are there from different societies, the American Academy of Neurology, NICE guidelines, there are many guidelines. There's another thing that we have to keep in mind. When the patient's lung function goes down a lot, they are not going to be able to lie down flat for you to safely do the PEG. So it needs to be timed before the patient loses too much weight. It needs to be timed before they lose too much of muscle strength for breathing. Otherwise, the procedure itself puts them at risk of respiratory failure. And that's counterproductive. So timing the PEG early, I think it's a good idea that if you have anything like heading beyond 5 to 10%, beyond 5% of weight loss, be very cautious. 10% of weight loss, start thinking about supplementing the nutrition of the patient, because there's no benefit to the PEG if they're already malnourished. We are behind the curve. They're already going to get more infections. So we want to do any kind of feeding intervention and preventing aspiration intervention before they lose that. Tracheostomy is a much harder question for patients to address because it has a lot more impact on our sense of self, on our image of who we are, what we are, how we communicate. It might seem like just one step higher than a non-invasive ventilator, but it's far more. And while we do tell patients that it can be reversed, right? There was a study in the UK which looked at how many patients in the last 5 years or something were on tracheostomies with motor neuron disease. And it turned out that 50% of them got the tracheostomy acutely when they came into an emergency room. About 50% of them got it reversed within a few months. And most of them chose not to go back onto it. So it is a huge quality of life shift. As long as we have access to NIV, we would try to avoid this. The big advantage of a tracheostomy is better access for clearance of secretions. So if you are having worsening respiratory muscle weakness and one is considering an ICU at home model, where the patient is connected to a ventilator, has access to home care services, easier access for suctioning, there will be fewer hospitalizations. There'll be better management of secretions with the tracheostomy. So it's important that we start these conversations well before any emergencies to understand what the patient's values and preferences are. This has to be in alignment with their values and preferences. So it's not a unilateral decision from a doctor's side. It really should be something that we plan very early on. And that's why it's important to monitor these things, the peak cough flow, the forced vital capacity, doing the respiratory monitoring. We have to keep a plan for acute respiratory emergencies. When you have a non-invasive ventilator, you have an oxygen concentrator, you need electricity backup. If you're in Bangalore, you most definitely need electricity backup if you're on all these equipments. There's some states like Kerala which actually give you free electricity if you're any kind of life-sustaining device. So I wish more governments would take up that initiative and support patients who are on ventilators at home or any kind of non-invasive ventilators at home. Have phone numbers ready for who we need to call in case of emergency. When the patient is not able, is disconnected from their NIV or ventilator, a simple technique, not a simple technique, it's it's complicated to learn, but it's a technique that can be taught by the speech and swallow therapists called glossopharyngeal breathing, can help them tide over until their caregiver can come and troubleshoot what is wrong with their non-invasive or invasive ventilator. Having suction apparatus and a backup for manual bagging or a ventilator is a good thing. Most importantly, we have to discuss emergencies and have advanced care plans done as soon as you start seeing patients coming in with more and more respiratory symptoms. So I have patients who are initially coming in every 3 months, every quarter for assessments. A couple of infections go by, now they're coming in every month. Even though they're doing fine, they're eating, swallowing fine, breathing fine, I need to make sure that I've discussed advanced care plans with them already. What to do about ICU? You can still go to the ICU because it could be an acutely reversible thing. It's not that if I say I do not want to be intubated and I do not want to be resuscitated, does not mean no ICU. I'm sorry, I'm going over time by a minute or two. Important to discuss goals of care. It is always possible to withdraw non-invasive or invasive ventilation. Just like we can stop antibiotics and dialysis, we can stop ventilation if that is what the patient so desires. There is no legal problem with withdrawal of NIV or invasive ventilation if that is what the patient's wishes are, as long as you have consensus and it's medically appropriate at that time. Quick word about opioids, very important. They reduce the sensation of breathlessness on multiple ways. We shouldn't be afraid to use them. All principles of palliative medicine apply. Start low, go slow. Usually just need 2.5 to 5 milligrams of morphine, immediate release as needed, always with a bowel regimen. And this is for breathlessness at the end of life. It's important that we also take the caregivers along in our management plan and support them, because they are the ones at the bedside. They know it all much better than the doctors and nurses who come and visit the patients sometimes. So this is actually words from patients. How do we plan ahead for addressing the respiratory changes in motor neuron disease? Some of the patients who are on devices said, embrace the technology. So using non-invasive ventilators with a mouthpiece ventilator will allow you a lot more function. Embracing technology in terms of text to speech, all of these things making their wishes known. For us as providers, be familiar with the use of all the technology as well as the medications. Thanks.
Sure.
Snoring, people snoring now. And the husband snores, what wife to do? If wife snores, what to do?
So it's most likely sleep disordered breathing. So it's a disorder of sleep as well as breathing, and they need a sleep study. And after that, a polysomnography, and then we can figure out what intervention is needed.
Thank you, Dr. Rajni. I now request Mr. Vasant Rao to hand over a certificate of recognition and acknowledgement.
Dr. Rajni Bhatt just mentioned about the devices of the respiratory devices. We have a stall outside, and maybe after lunch or during lunch, you could have a networking. And there are people from Philips who will be able to give you a lot of demonstration on the respiratory devices that they have. Thank you.
I now invite Dr. Roop Gursahani, consultant neurologist, PJ Hinduja Hospital, Mumbai, to give his talk on palliative care in ALS.
Yeah, I think I'll have to avoid that step. Is it? Oh, is it mobile? Yeah, it is. I thought it was fixed. Right. Thank you so much, Mr. Vasant Rao, for inviting me here. And of course, our tributes to Dr. Shama Narang. I'd also like to thank Dr. Nalini, Dr. Sina for putting this all together. And I'd like to actually begin by pointing out that my journey into palliative care actually began in Bangalore with Suvarna, Priya, Rajni, way back in 2017. So I can now perhaps call myself a neuropalliativist because I do both. But just to tell you that palliative care is the active total care from the time of diagnosis, focused on improving the quality of life for both patients and families through prevention and relief of suffering from all kinds of physical and other symptoms, and preferably through socially acceptable and affordable interventions. As you can realize that this is a long definition, one of 17 that's available. This is from the Indian Association of Palliative Care. And palliative care is actually a specialty that began in the 60s, largely because of one remarkable woman. Dame Cicely Saunders, who passed away in 2005, started as a social worker. In the Second World War, became a nurse. And as her scientific accomplishments, especially in the use of morphine and all that, rose, she was told that no doctor will listen to you if you're a nurse. So she actually qualified as a doctor. And this is the quote that she's most remembered for. You matter because you are you. You matter to the end of your life. We will do all we can, not only to help you to die peacefully, but also to live until you die. And one of the themes that we use for palliative care is hope for the best, but prepare for the rest. Amongst other things, she's also known for the concept of total pain, which encompasses not just physical, but also psychological, social, and spiritual pain. It's a concept that you actually have to see in action. Most of us think of palliative care coming in towards the end of life. That is not really so. It is applicable to all serious health-related suffering. Eventually, of course, it shades into end of life and terminal care. And when palliative care is involved, it assesses needs across the whole spectrum of human life, sets goals of care, and manages all symptoms. And you will wonder to yourself, why was it that this specialty didn't really come into existence earlier? It was only when in the 1960s that people started to survive with serious illness that it became obvious that you needed a specialty that went across boundaries, an intersectional specialty like family practice or intensive care, but now towards the end of life. For me personally, it is in a sense a mental pivot. As a neurologist or as a physician, curative medicine is what I'm at. I seek to return patients to their own lives so that they can do what they want to do. In palliative medicine, I seek to assist patients in leading their lives and support them in the pursuits that they wish to prioritize in the time that they have left. Actually speaking, we do both together sometimes for decades. And MND is a very special challenge, recognized a long time ago. Read this quote from a senior teacher in neurology many years ago. The best test of a physician's suitability for the specialized practice of neurology is not his ability to memorize improbable syndromes, but whether he can continue to support a case of motor neuron disease and keep the patient, his relatives, and himself in a reasonably cheerful frame of mind. So I'm going to actually frame this through the life story of a patient that I saw. A 53-year-old gentleman, a practicing lawyer, seen in November 2017 for difficulty in using the right hand. He had clearly wasting and weakness, no sensory findings, brisk reflexes, the phenotypes that Dr. Nalini described. And when I saw him, I knew what it was. So I advised investigations. And as we were finishing, I told him, maybe this doesn't look good, but remember, whatever it is, whatever you want to know, if you want to know, I am not going to hide anything from you. And I left it at that. The EMG confirmed the MND, but the reports are brought in not by him, but his wife and the wife's younger brother. We don't want him to be told. And again, I kind of obfuscated, bought some time by sending him off for a second opinion. In Bombay, if it were Bangalore, it would be Dr. Nalini, obviously, but it was in Bombay, so it was Dr. Khadilkar. Anyway, and remember that when I make a diagnosis like this, it's not the patient's business to know the landscape. It's mine. I am the Sherpa that is going to walk along this patient all the way through. And obviously, I need to know where we are going. For anybody who wants this picture, it's available free. You just have to take it from the article that it is referenced in. It's just been published. So I'll be discussing this a little further as we go along. Remember that once we make a diagnosis, and sometimes now these diagnoses can be preclinical. There are things that we do as professionals. There are things that happen along the way. So information is a pretty important thing that can come through support groups. Symptoms will obviously come along the way. So will disability. So will life events. And you have to be there. Now, the problem is that when you take the last line that I left that previous slide at, we don't want him to be told. Many doctors drop the ball at that point. Why do they do that? Because these are difficult conversations. Most doctors avoid them. And if you ask anybody around, they'll say they are stressful and they don't feel confident about them. But there is training available and there are protocols that you can use. They said they are time consuming. No. I usually finish them well prepared. I finish them in 15 to 20 minutes. And once it is done well, further questioning goes down. Honesty destroys hope? Nope. Transparency reduces anxiety. Prognosis is uncertain, and you heard it from Dr. Nalini that our Indian patients can have a wide spectrum. So yeah, we don't tell them so many years. Never. We identify signposts of decline and point out the road ahead. Obviously, different people will take different time to go through different parts of the route. Sometimes things may not be certain, but accepting uncertainty is completely acceptable. In fact, this uncertainty allows hope. So we have to accept it. Yes, some patients, families may reject our diagnosis. Yes, get a second opinion. The last is that if we say yes, yes, that death is somewhere ahead in the distance, that is accepting failure. No, it's accepting reality. It allows us to work with patients and families at maintaining quality of life till the very end. So this is what we have to challenge. We call this collusion. Collusion is when the doctor and the family together hide things from the patient. It's a huge thing in cancer. It's a very major thing in MND also. We call this the conspiracy of silence because eventually the patient also stops asking. The patient knows something is going wrong with her. And she doesn't want to ask because she sees that the family gets upset. So this conspiracy of silence binds everybody together. We begin this because we want to protect those whom we love. But the consequences are anxiety and mistrust. And that mistrust leads to desperate cures. People go for stem cells. And palliative care absolutely needs. You heard Rajni speak. I mean, how can you take a patient through all those decisions if the patient doesn't know what they are heading for? So, as I said earlier, there are protocols and doctors can be trained in the protocols of how to have these conversations. So these protocols include putting the setting together, ask the family what they know, check if they want to know, then give information. Usually the information has to be in small chunks and so on. But the first statement that I often use is to take this on my shoulders and say that this is my responsibility. It is not yours. And remember that the immediate family is desperate. They've been hit by a bomb. And if you say, this is mine, they'll say, take it. It's only when it goes out into the wider family and the chacha and the mama and everybody come in and everybody starts building up this nonsense of do not tell, do not tell, do not tell, that it gets worse. So it's always the first doctor's responsibility. And this is a shot from one of our major textbooks in neurology. remember this, the first step in the management of ALS is to present the diagnosis in a compassionate yet informative manner. There's lots more that comes into this, which I'll be running through, and you'll be able to see how it works. So when he came back, the first question was obviously, what have you heard, read, understood? Because he'd also, come on, smart guy, already onto Google and stuff like that. So we went through what he had already understood. And then I asked him, do you really want to know? He said, Doctor, mujhe jo kuch ho raha hai, mujhe batao. So we discussed this and we started the standard medications. Riluzole and edaravone was planned. And remember that having done this, we had, I think at least we'd gotten around to building the trust that was necessary for the long haul ahead. Typically in situations like this, I have yet one more follow-up visit in another 2 to 3 weeks, because there will be questions, there will be discussions, and then we set up a follow-up schedule. It can be as long as 6 months, it can be 4 months, and as time goes on, it becomes shorter. But typically, as they leave the door, they ask me, when should we come back again? I say 3 to 4 months is the usual ballpark, but you decide how soon you want to come back. And we set mechanisms of contact. WhatsApp is hugely beneficial. And I'm fairly protective of myself too. So I really don't take calls, except towards the end. And therapeutic options have to be discussed. You have to look at expense, feasibility, and evidence. There are people who will mistrust modern medicine, who will want Ayurveda, or who will want stem cell therapies, which is a complete scam. If you look at it, the scamsters extract just about 3 to 4 lakhs. They don't extract unreasonable amounts. So most people do end up paying that if they have fallen through the gaps of our communication. And so was our gentleman. But he came back before that to check with me. I spoke to him in detail. I also had to check for depression and suicidality. And amazingly, he was very clear in his mind. And so actually, it was a little late. I should have done it the first time around. I started him out on physio. His wife and daughter joined the support group, which is now largely online in Mumbai. So remember that a support group is an extremely important intervention. Basically, people with common experiences and concerns who can provide emotional and moral support for one another. This is obviously due to a characteristic that is difficult to handle. This is non-professional and non-material help. Largely, it's information sharing, especially coping strategies. And it's also relating, hearing, and accepting each other's personal experiences in a shared safe space. It allows them to build community, and it permits advocacy. For uncommon diseases, online support groups work very well. The only problem is it's not very easy to find a reliable one online on search engines. But if they do work, participation can be asynchronous. And often we don't realize how much information and support is possible online. Ideally, they should be caring and compassionate, active and vibrant, and they should have a true sense of community. I'll leave you to check out the reference at the bottom. It's by an authority who handles this, and it's pretty useful. But the other important thing that started off here was his physical rehab. Now, in physical rehab, remember that range of motion is pretty simple. It's a first-line treatment for cramps and spasticity, and it can be designed by a therapist so that it can be done by the caregiver. The next are aerobic exercises. They are safe, maintain cardiorespiratory fitness, and are beneficial for mood and well-being. And you do these together with monitoring respiratory function. Some patients, actually this patient, wanted to know about weight training, and I referred him to somebody who could supervise him and use just mild to moderate resistance. Basically, you watch out for overwork weakness, because that can be harmful and you have to avoid that. Time went on a little fast. By May 2018, barely 6 months later, he was already having speech difficulties. He was drooling, but he was walking well and doing well at physio. In fact, he's told me that my wife and I go together to the physio center. She works out and I do my workout. But he had lost 5 kgs of weight. And I wasn't really sure whether this was the workouts or whether something more was happening. So there are multiple symptoms that come up as you go along. Spasticity, cramps, and fasciculations are all symptoms that should be manageable. The first line management is pretty simple. It's non-pharmacologic. But if you do need pharmacologic treatment, for cramps, you have quinine, not very easy to use. For spasticity, baclofen can often be used. And for fasciculations, you can use anti-epileptics, and we'll skip this part. But the other symptom that bothers a lot of patients is drooling. It's also seen in Parkinsonian syndromes. It's due to both increased saliva production as well as impaired swallow. And you can use drugs called as anticholinergics. These are typically antidepressants, and these are pretty easy to use. But the easiest I find is 1% atropine eye drops. 1 drop in the mouth keeps the mouth dry for about 3 to 4 hours and can be used. We use them a little carefully, but they can be used. For really severe cases, you can do Botox injections. You can even radiate the salivary glands. The other big problem is pseudobulbar effect. Excessive uncontrolled laughter or crying. Typically, it's crying and it's very distressing. You can use standard antidepressants, clomipramine, fluoxetine. The standard drug combination of dextromethorphan and quinidine, it's a drug combination. Quinidine is not easily available in India, is not available in India. But the last is something that needs to be highlighted. Cognitive deterioration is possible, occurs in 20 to 30%. And the longer we go, we need to pay more and more attention to it. Memory is not so much an issue as is judgment. The person's judgment about how life is affecting not just themselves, but people around them tends to decline. And this is important because this impacts the carer directly. Carers are the mainstay and anchor for these patients with life-limiting neurological illnesses, and there are multiple roles. Care partner comes along with the patient for logistic reasons. Caregiver actually takes care of the patient, and then of course in India we often have paid care assistants. And you have to pay attention to who cares and why. What is their relationship? What is their own health status? Remember that they will need to give physical assistance for all activities of daily living eventually. And towards the end, they will be the surrogate decision makers. So there is a large burden on them. It impacts their health. It causes psychiatric morbidity. There's a risk of burnout. And there is anticipatory grief. You are seeing the person you love go away gradually, day after day. It's not easy to live with that. And for us, it's important to acknowledge that and perhaps even systematically assess it. There's the Zared Burden interview is available. And so you understood at least what palliative care does in these early parts of the illness. Not so long later, just about 3 months later, he actually came in a wheelchair. And this was the key consult that I had. We spent almost an hour. And of course, I had done my basic examination and I was preparing to ask this question and I did shoot this. Aapke man mein shanti hai? Are you at peace? And it was like a river burst out. Even his daughter who was there was surprised because the things he said that she hadn't heard. One was there was a family issue regarding property which he wanted to settle. And he absolutely wanted to go to this family home that he had been building just outside Mumbai, his second home. He wanted to go there once because the family said, how will we take you? How will we take you? I said, go. And I brought in the subject of PEG at this time because obviously this was something that was coming up. Now, the Man Mein Shanti Hai is a spiritual question. It leads into spiritual discussions. Unfortunately, we do not have resources for this. So when you look at spiritual care and needs, the big questions of life are, why is this happening? Then what gives me comfort and hope, joy? Who are my beloveds? What or who beyond myself do I believe is important in my life? And there are many resources that people can use. Again, I am not the expert on this. Unfortunately, we are completely devoid of experts on this, partly because our belief that we are so spiritual that we don't need this. Anyway, so ideally you need people who are trained in providing what is called pastoral care, who can take people through these existential difficulties. That's really important. And as I said, we had to come up to the point of the peg. I'm really happy that Rajni and I, although we didn't really see each other's presentations, we could kind of combine. So Rajni has already taken you through the decision making for a peg. The peg has to be put in ideally before the forced vital capacity drops below 50%, because beyond that, you're at risk of ending up in getting an intubation during it. The endoscopic gastrostomy is done through by endoscopy, and with a kit, you directly insert the tube into the stomach, and it's pretty comfortable, and it gets hidden under the clothes. What does it do? Done in time, it prolongs survival by 6 months. 6 months. So it is absolutely important that we speak to our patients and get it done. And I don't find any difficulty in getting my patients to accept it. Right? So the peg was done. In fact, his FEC at that time was still 70%. And he had some minor leakage and so on. And the next conversation was about respiratory support, non-invasive ventilation, and a tracheostomy. But there was also this question of food. Fortunately, when the peg was done, he could still take solid food orally. Only water and medicines went through the peg. And remember, Rajni spoken about this, but NIV also prolongs life by about 1 year. NIV or the use of a tracheostomy. And you need to put this in as soon as possible. This is because the question of a tracheostomy is a fraught one. It's difficult. The reason is it can give you survival indefinitely. Of course, nobody survives indefinitely, but eventually the person ends up in a locked-in state. Not even eye movement, no, absolutely no way of communicating with the outside world. And it's not something that most people want, though it has other advantages, which Dr. Rajni pointed out. One of the things that it helps is it frees the face, so you can even read. But there's a risk of infection. It greatly increases costs. It increases family and caregiver burden. And then we end up with ethical issues about discontinuation. Now, for some time ago, we used to be scared that once somebody went on a tracheostomy, they could never come off. That story ended in 2018. This is the law of the land. This is the major Supreme Court judgment in 2018 that covers all of this. And it's extremely clear that if an individual either before or during that period says, no, I don't want this treatment, you cannot force it down them. So, as I said, we'd been through most of these except the food part. And that too was an important point. This is because we, in palliative care, we have been focused on managing suffering. But how do you manage suffering? How about giving them a vaccine for suffering? Joy. And if you enhance joy, you free them from the role of patient. They take charge of their own lives. And what are these joyous interventions? They're simple things. Spending time in nature, spending time with family, eating your favorite foods, having your favorite drink. And if people can do that, if you can discuss what do you enjoy, what are you looking forward to, you move beyond this medical decisions towards life goals and making an individual feel alive. So that part happened. His next complaint was, I'm a foodie. I get the taste, but it's all mashed. I said, okay, Baba. Anyway, so we were now in March 2019. His wife was a working professional, so he was being looked after by a ward boy through the day. And this visit, the palliative care physician was also another respiratory physician who's moved to palliative care, Dr. Raja Mayyar. We were both kind of managing between us. We checked for pain. We checked for morphine side effects. He was on regular morphine by then, and we discussed end of life options. The way to move into that question was, would you want to move to hospital if things were worse? Or would you want an ICU? The tracheostomy discussion had already happened. So you know that he was much, much clearer. Now, I'm not going to dwell too much on this diagram, except to point out that for those of us who think that motor neuron disease is a pure motor problem with no sensory involvement, that is wrong. There are many sources of pain. Again, this is a free on the net article. You can look this up, and we have to actually pay attention to all of them. It could be as simple as being unable to move. Just lying in a single position, just try it out. If you can lie completely flat for 30 minutes without feeling it, it's not possible. So when you start these discussions, there are three components to these discussions, and they flow between each other. The first is goals of care. You're basically actually educating them about what is happening, how it is happening, and it's combined with the usual discussion about treatment and so on. Then you go beyond that to documenting this information, making it actionable, and the most important point is identifying a proxy decision maker. Here his wife was there, and it was very, very obvious that the wife and the daughter were going to be taking decisions jointly, so I didn't really need to do much on that. And with this, then you come to shared decision making. I hope you realized that my decisions or whatever we did, it was a patient leading all the way. And that is what matters. So advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences to help ensure that they receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. It's a bit of a mouthful, but I hope you get what it means. But what does it actually mean? It's actually an umbrella term. It applies to living wills. It applies to appointing a surrogate. It applies to goals of care. POLST is physician's orders for life-sustaining treatments. In India, it's called the DNA CPR form. So all of these are part of advanced care planning, and obviously it gets more and more intensive as you go along. The first priority is to have a healthcare power of attorney if there is no obvious person there, then goals of care, and then planning for emergencies. And that is what medical orders for life-supporting treatments are. By June 2019, he was communicating with a laser pointer, and Dr. Yamini spoke about alternate and augmented modes of communication. I wasn't able to discuss that, but there's a lot that you can do. He was on round-the-clock morphine. The married daughter was not now spending alternate nights to spell her mother through the night. And the hospice care had moved on to WhatsApp. So both the wife and the daughter, the palliative care physician, and somebody else, I think one of the relatives, we were all in a WhatsApp group, and we were kind of touching base and seeing what was happening. But we still missed when he actually deteriorated right at the end, because he stopped breathing one evening and the wife was there alone at home, and she panicked and she brought him to casualty, which ideally we should have actually anticipated, stepped up medications, and as he wanted to be at home, we would have been able to achieve that. My journey actually in all of this began in 2011. I was in the Aruna Shanbag case, but from there it went on to advocacy and then to palliative care because of a realization at the time of that Aruna Shanbag judgment that as a citizen, as an Indian citizen, I had no control over my own last days. And as a physician, I could not help my patients till the last. Ab main kuch nahi kar sakta. I can do nothing more. Would choke me to say it, but I had no choice but to say it. Now, I don't think I ever need to say it again. So I hope you've understood how we as doctors bear the responsibility of helping patients and families through this long journey. For those of you who are interested, you've seen the INPCS on some of my slides, that the International Neuropalliative Care Society is based in the US. I'm on the board of directors. And if anybody is interested in understanding more about neuropalliative care, because that is substantially different from oncopalliative care, I suggest you navigate to inpcs.org, look at the education drop-down box. The next cohort will start on the 1st of September. That we postponed that a bit. You're welcome to join me. And if anybody wants this presentation, please do email me. Thank you. Perfect.
Thank you, Doctor. I now request Dr. Bhargavi to give him a certificate of appreciation. Thank you. Thank you. I now request Dr. Suvarna Aladi, Professor and Head of Neurology, NIMHANS, Bangalore, to give a talk on cognitive and behavioral changes in MND.
So after that simply wonderful talks, 2 talks by Dr. Roop and Dr. Rajini, I'll just spend very little time, I promise. But I would also like to bring forth another under-recognized area in motor neuron disease and in ALS. And I'm grateful to Dr. Nalini and Vasantrao for including this topic in this very multidisciplinary meeting. Like Roop took us through the story of one person, I think we've all learned, like Shama Narang her life has taught us something. We're also learning from the persons who live with this disease. This was when I just joined NIMHANS a few years ago, about 8 years ago. This gentleman, he came with his son, and the son said, my father is not able to express himself. It was a 2 years history of progressive language disorder. So I'm a person who works with people who have dementia, who have cognitive problems, memory and language with the team. So we tend to see people who have cognitive problems, they come refer to us. So this gentleman had problems remembering names. He was speaking less and he was mispronouncing words, and he was talking little less. He took a little longer time to do things. We call this executive dysfunction. And you can see in the brain that the left side of his brain, where the language areas are, the frontotemporal areas, there is some shrinking. And so we have a name for this disease, and that's called non-fluent aphasia. That means the person is not speaking very well and he has a language disorder. It's a kind of dementia. It's a kind of frontotemporal dementia. So we made this diagnosis and we started speech therapy and all of that. Within 6 months, he came back to us. And by this time, he had progressed to mutism. He was not speaking at all, which is a little unusual for non-fluent aphasia. They tend to be independent for many years. They don't speak much, but they tend to be independent. But if we had gone by conventional kind of diagnosis, it's a pure cognitive disorder. It affects cognition. They move well. Their motor systems are fine. Their sensory systems are fine. And then, you would probably just say that disease is a degenerative disease. It's progressing. It's quite possible that, you might actually forget to test the other neurological system. In this patient, when we asked him to open his mouth, he had gross fasciculations in the tongue. And this is something that we might have missed completely, if not for the fact that we know that these two conditions can coexist and that the natural history is not so rapid. So we, as doctors, I'm now talking to the residents here, we have to know, and all of us here, we really need to know what is happening in the field. And this patient really had, within a year, full-blown ALS, and he succumbed within 18 months. So in addition to having a non-fluent language disorder, which is a dementia, he had a motor neuron disease, that is ALS. There was another lady who came, and the daughter said that her mother was behaving strangely. So she'd become very stubborn, inflexible, very self-centered, ritualistic, obsessive, and superstitious, quite disorganized, disinterested. It's all behavioral problems, really. Some difficulty in recognizing objects and words. And then when you examined her, she was not paying attention. She was a little disorganized and maybe not naming very well. Again, she had atrophy in the frontotemporal areas of the brain, a classical frontotemporal dementia, which we call behavioral variant of frontotemporal dementia. But again, within a year, she came back. This is unusual for a typical behavioral variant FTD. It's not purely a dementia. She developed slurring of speech, difficulty in swallowing, and again, full-blown anterior cell disease. And she had a family history of not of MND, but behavioral disturbances, again, not amounting to any dementia, just some brother who was behaving oddly at times. And in this patient, you can we were able to detect a novel mutation in the TBK gene, And this is actually, this publication is truly a collaboration between the MND group and the cognition group. This was Sina when she was very young. She ran around, I think, drawing blood from some 15 family members. And then now moved to the next generation neurologist, Dr. Fahim, who actually finally wrote it up with Dr. Nalini, and all of us are there in this together. So this really represents a collaboration of groups of people who come together and try and identify what is the cause of this disease and this particular combination. But then there is the person with motor neuron disease, typical ALS, 43-year-old lady. She had the kind of phenomenology you saw with Dr. Nalini's presentation: weakness, wasting, fasciculations, brisk tendon reflexes, some difficulty in swallowing. So you would say ALS. But when we examined her, she was irritable, anxious, indifferent. It could just be part of the disease. And I trained here in the 1990s, and Dr. Nalini will remember, we remember so many patients like this who had ALS, who were irritable, who were anxious. And I've heard Madam Gauri Devi also say at that time, we didn't really think it was part of the disease. We just thought they were worried. They couldn't communicate very well. And she had some delusions of reference, but essentially cognitive testing was normal. So, but if you're aware that people with ALS can have neuropsychiatric symptoms, delusions, anxiety, panic as part of the disease, then you would really think it's a combination of behavior and ALS. And she had a C9orf mutation, again, a genetic form of ALS with neuropsychiatric manifestations. And I think this is something Dr. Rajini will be kind of happy to see. There was a person who came, this is a report, this is not our patient, a progressive motor syndrome, this gentleman with features of ALS for a couple of years, dull and depressed since a year, but decided not to have life-prolonging treatment. Experienced respiratory failure, but the emergency doctors, Dr. Roop, the patient, when they come back to the hospital, sometimes they change their mind. They provided ventilation, and after non-invasive ventilation, the depression disappeared. And then this gentleman has said, one has the right to make errors sometimes. So this is just reactive depression. This is a depression that improved with ventilation, in fact. So you can now see the range of behavioral and cognitive symptoms, and this is just a tip of the iceberg. Each patient is different from the other. We don't know one patient like the other. And I think between the combined experience in this group, we just have so many stories to tell. So you can have a progressive aphasia with ALS, behavioral variant FTD with ALS, just neuropsychiatric features, no dementia, depression. You can then, on the other end of the spectrum, you have a pure motor syndrome, and they do not have any cognitive and behavioral features. It's not that all of them should have. So this has been grossly under-recognized. This is Charcot. He's a god of neurology in the 19th century. When he described the first person, he said the mind is unaffected in ALS. But then his protege, like all good proteges and students should be, disproved his teacher. And within 23 years, Pierre-Marie said that mental functions are altered over the course of ALS. So you can see how knowledge grew, but it was recognized so long ago. And this is the first pathology picture, again, in the 1947, where they demonstrated atrophy in the motor and premotor areas. Again, history from the East. This is from the Journal of the Medical Society of Yokoyama in Japan, where if language disturbances were described with ALS, and this is in the script kana and not in kanji, and therefore it was recognized that just like you can't move, you can't speak, you can't write. So cognition and motor functions are so closely, they're all forms of embodied cognition. So writing and speaking is also impaired. And this is something that was recognized way back. So over the next century, about 174 ALS patients have been reported. But even so, the L-Escorial diagnostic criteria did not carry cognition and behavior as a manifestation. But it is the concerted efforts from the frontotemporal dementia groups. I'd like to mention my mentor, John Hodges, and Thomas Bach and a whole lot of them in that early 2000 when I was doing my fellowship in Cambridge, the C9orf mutation was described, and then it was a game changer, and we realized it was all part of the spectrum, and now it has made it into the revised criteria for ALS. The reason I'm talking about history is because there are many things about the disease we still don't know, and it's up to the youngsters here to actually discover them, and it's very exciting times now. So you've heard this many times. A significant proportion of people with ALS have cognitive behavioral problems, which can occur before, during, or after. Typically, more cognitive impairment, more disease duration, more severe the disease, and worse the prognosis. We've heard about it being a multi-system manifestation. It's just not motor, it's beyond that. And the reason this is important is because patients really need to know what they're dealing with. Imagine a person who can't think, remember, judge. We really need to understand that produces care a burden, affects prognosis, and affects the way we treat the patient. The most common cognitive deficits are being disorganized and not being able to plan with language disturbances. And they're also having problems with social cognition. They can't see what the other person is going through emotionally. It appears they become a bit cruel, but memory and visuospatial deficits are less common. And these are associated with specific areas in the brain, prefrontal for executive dysfunction, language areas for language, and so on. Depression, mild depression is very common, but moderate to severe depression is not that common. It could well be apathy. Suicide is rare, but they have a higher risk of suicidal attempts. Delusions are very common, more so in the genetic form. And pseudobulbar effect, of course, is common even in the pure motor syndrome. So you can see now that ALS and FTD are a spectrum with significant overlap. So just like you have so many varieties of motor neuron disease, you have that many cognitive behavioral syndromes that are associated with ALS. Now, again, as Madam also mentioned, Dr. Nalini, a significant proportion have features of both. Now, you heard from Dr. Nalini, why is it there is so much heterogeneity? What is the reason one person does not really look like the other? This is because the pathology in the brain is quite different in both the varieties. When it's only motor disorder, it's predominantly in the motor cortex. It spreads down to spinal cord and brain stem. But later, even in the pure motor forms, it spreads to the frontotemporal areas. On the other hand, if it's behavioral and cognitive, it's the frontoinsular areas, and then prefrontal, and much later coming down. So you have these cluster of symptoms. And the current thinking is that it's not just localization, it's also a network. Why are these areas? These areas are connected to each other. Neurons that wire together, fire together. So there's a predilection for why this pathology moves in a particular way. And I think this is where research is heading. It will help us tell our patients what they're likely to expect in the future. So you have so much variability, different sites of onset, spreading, different survival trajectories. So this is where research is now. And our brains are, why is it like that? One, it could just be the gene. A particular gene spreads in this way, but it's not so simple. Different people in the same family have different trajectories. It's also development. How did your brain develop? And then over life, what did you do with your brain that developed certain networks strongly and certain networks became weak? And based on that, the disease pathology seems to be affected. With C9orf mutation, it is now possible in a few cases to predict the area, but it's still very, very nascent in its in understanding. While C9orf changed the way we understood FTD, now more and more genetic mutations are being described where ALS is occurring in combination with FTD. And there are many different pathophysiological pathways. You'll hear tomorrow from the basic scientists. And why is it important? Why is it challenging? If you have only a motor disorder and you can't speak, you can't test cognition. If you are very behaviorally impaired, you cannot test cognition. So when you have a combination of psychiatric, cognition, and movement disorders, it's so difficult to assess them that you leave one out at the cost of the other, which is why we really need to make an attempt to use the right kind of tests. And these are some of the tests that have been validated for ALS and cognition. And these tests actually do pick them up quite well. management, we don't have much, but for the cognitive deficits, non-invasive ventilation again improves memory. And then I will not go through the other drugs. There is just not much evidence, but oxytocin, the nurturing hormone, seems to have a beneficial effect. Similarly, for behavior, environmental modification, how we interact with them, and of course, when necessary, a short spell of medications and a lot of music therapy and meditation and all of that, there is evidence that is building up. So finally, how do we approach cognition and behavior in ALS? You have to have a low index of suspicion. You have to believe that you really need to understand their cognition and behavior. If it's fine, you can do so much. If it's not so fine, you can still do a lot. You need to identify which area of cognition or behavior is affected. So you get a complete clinical picture in the patient. It's possible that family members can have just either autism or schizophrenia or Parkinson's disease. So you need to get a complete family history and then kind of identify the known gene if it's possible, neuroimaging signatures, confirm with genetic testing, and early management has significant positive implications for outcome. Like to end here, I have Dr. Saraswati who always looks for treatable causes in our department. So this is a patient who came with a picture of subacute progressive memory loss, behavioral problems with LMN-UMN findings, but patient had antibodies for which suggestive of paraneoplastic syndrome. So this is potentially treatable. So this is one case report that I came across. So we have to not assume that even this rare combination of behavior, cognition, and UMN LMN is degenerative. It could still be paraneoplastic. So this area is really growing. So to conclude, ALS, FTD are two extremes of a clinical continuum. They often co-occur, important to diagnose and identify which domain is affected. We have to do cognitive screening and if necessary, neuropsychological assessment. Is it a social cognition problem? Is it a semantic memory problem? And then most importantly, the clinical trials are not including cognition as an outcome measure. Even research studies, it's only in places like NIMHANS where we've been looking at both together in everything that we do, but in most places, they're still working as silos. So it's really important to integrate cognition and behavior into clinical trials. And again, Dr. Roop was mentioning cognition has an impact on patients' decision-making ability, end-of-life care, financial planning. We have to factor that in. And most importantly, I think rehabilitation is crucial, and families and it's the families that are actually coping with most of the problems, more so if there is cognitive impairment. So extensive psychosocial support is required. So it's a large team that works together over the years. So thank you very much.
Thank you, Doctor. I request Mr. Vasant Rao to just hand over a certificate of recognition and acknowledgement.
We will now break for lunch. And I think we are running a little short of time. We'll break for lunch for 45 minutes, but I promise you a solid lunch. Secondly, after the lunch, we have the talk by Gustav Zbeta, who has flew all the way from Bolivia, traveled over 60 hours to come to give us a talk here today. And I think it's going to be one of the most exciting talk. He's going to talk whether hypoxia can be a treatment for MND. After Mr. Gustav talk, we will be having another talk from Carlo Angelini. It's going to be online. He is in the striking distance of finding certain cure for motor neuron disease. I would strongly recommend you to see his online talk that is after Mr. Gustav's talk. Thank you very much. Enjoy your lunch.
Dr. A. Nalini, Mr. Vasant Rao,
Professor Gatisek, your nose and
Your mouth cannot speak either. So it is important the energy. You need, when the healthy control breathing and how to swallow.
Thank you, Dr. Yamini. I now request Dr. MND.
You can see now that ALS and FD important to integrate cognition.
Thank you, doctor. I request Mr.
It's good. So that is optimistic.
Okay, perfect.
Your place.
For you?
For you.
Welcome back. Hope you all had a good lunch. I now invite Dr. Gustavo Zubieta. Dr. Gustavo is the head, High Altitude Pulmonary and Pathology Institute, La Paz, Bolivia. He's come all the way from Bolivia, traveling 60 hours. So I invite Doctor. He's going to give a talk on can exposure to hypoxia and chronic hypoxia be beneficial in MND?
Thank you very much, Ala. I feel profoundly honored to be here, and I definitely want to thank Basant Rao for all his effort, his enthusiasm to bring me here, and Nimhan's doing all the effort to help all these people that we have seen the severity of this disease. Professor Venkatesh is frequently making challenges to my neurons to come up with ideas about new things, okay? So I don't know what he has planned for the next time, but this time, this talk is totally unconventional. It's based on my work at high altitude over many, many years. And I think it's a very interesting point that has to be looked into for this terrible ALS and MS disease. So this is the place where I live in La Paz, Bolivia. You see, this is located in South America, and we are going in a telepheric, in a cabin, and filming this city. It's located at 12,000 feet, 360 meters above sea level. It has life as at any place in the planet at sea level. This is completely normal life. There's the Illimani up there on top, the mountain that's always next to us. And this is the center of town. Population, well, this is when I did this was 2 million. Now it's 2,700,000 people. Everyday life. Do you realize this is at 3,500 meters of altitude? Are these guys normal humans? Of course they are, you see? Of course we are, you know? So chronic hypoxia is different than acute hypoxia. If you're exposed acutely to hypoxia, I was just talking with one of your members here. He had a friend that went up to Himalayas very fast and obviously had a pulmonary edema and death. That's acute exposure, lethal in some, not in everybody, of course. Actually, it's not a very high incidence, but however, once you adapt to hypoxia, miracle things happen. And that's what I want to talk to you about. So this talk is, can exposure to hypoxia and chronic hypoxia be beneficial in ALS MND? Please have an open mind about this talk because it's new stuff. This is the city of La Paz, and we are located on the mountain where our barometric pressure is 495. Actually, it's between 3,100 and 4,100 meters. And you see, this is about 1/3 less the pressure of the atmosphere. And so, obviously, we maintain the same percentage of oxygen, nitrogen, and all these other gases. It's the same at any altitude. But what happens is, as the pressure goes down, all these values, like here at sea level, the inspired oxygen tension, arterial oxygen, and saturation, decrease accordingly 1/3 from 150 to 94, the inspired there, and the arterial blood gas to 60. Right now, all of you have an arterial blood gases around 100 or a little less. If you all get on a plane and we go to La Paz, you arrive at an airport at 4,100 meters, you will have, and we take blood samples, you will all have 60 of oxygen. Normally here, if you go to a doctor with a PaO2 of 60, you're going into intensive care because you are dying. There, everybody is walking like you have seen, and you would be walking up there. Why? Because this is the marvelous thing about exposure to chronic hypoxia and hypobaria. You see, this is the barometric pressure on the X scale and the altitude on the Y. And there's an exponential, as you decrease altitude, you increase, as you increase altitude, you decrease the pressure exponentially. So these are different places: La Paz, Chacaltaya, Sajama, and Mount Everest. This is the city of La Paz. Chacaltaya is where we have a pyramid laboratory, and Sajama is our highest mountain, where we carried a soccer game above at this altitude. And that's the peak, Mount Everest. And this is the oxygen saturation curve. And at sea level, you're close to 100%. And in La Paz, we're normally in 90. So during the pandemic, someone spoke to me and said, we treat patients when here at sea level when they arrive at 90. Well, we live at 90. So you see the difference. And then Chacaltaya and Sajama, and you see how it goes down to these levels. That is quite amazing, but it's tolerable. Human beings, animals, and plants on exposure to hypoxia, acute hypoxia, can have acute mountain sickness, high altitude pulmonary edema, high altitude cerebral edema, that can be severe illness and death. Now, by the way, this should not be deadly diseases. Nowadays, we have the knowledge. There are many ideas about how to prevent this. Nobody should die this. In our institute, during 53 years, nobody has died of high altitude cerebral edema or high altitude pulmonary edema. We obviously have all the resources, but above all, it's the know-how. So if you're exposed to you pass the acute hypoxia stage, then you go into chronic hypoxia. And in chronic hypoxia, you have a remarkable adaptation. It's truly remarkable. That's what I want to show you, and how we're thinking that this should be applied to ALS. And this remarkable adaptation brings forth normal life at high altitude. But it requires time. The time factor is crucial. If you go up the mountain very fast, you can get very sick, very ill. But if you go slowly up the mountain, no problem. So at sea level, we have a PaO2 of 98 millimeters of mercury and a PaCO2 of 40. Notice this is 40, the carbon dioxide that you all have right now, and around 40 hematocrit of 42%. This is the city of La Paz. If you arrive up there, then at this altitude, it has a range of 3,000 to 4,100 meters. The airport is actually located at 4,100 meters. It's one of the longest airways because the density of the air is so low that the planes have to go at greater speed. So when you go up, your blood gases will have these values, a PaO2 of 60 and a PaCO2 of 30. And most of you will have no problems, no symptoms. Some will have headaches, which is the acute mountain sickness, and some will have even nausea, anorexia, and some may, but very few evolve into pulmonary edema and cerebral edema, which can be obviously very dangerous. It's a danger if you don't know how to treat it. But if you go up slowly, your hematocrit gradually will also it's actually a logarithmic curve of increase of your red blood cells. And once it reaches the high plateau, that's when you have adapted optimally to the altitude. And you have a remarkable adaptation. Now, this is the picture I wanted to show you because, you know, after listening to the talk by Dr. Rajani Bhatt, Dr. Rup Kursahani, Dr. Shurbana Alladi, and the previous persons that were here, one can understand that if there's a place where there is sensitivity, where there is solidarity of the physicians with disease, with a disease that as terrible as ALS, it's India. India has this remarkable love for nature, love for animals, for elephants, and they love humans in such a way that they care for them like they would not care anywhere else in the planet, in spite of having great resources. So when Dr. Malali Gowda, who is up here, and Dr. Prithvi Chakrakarti right there, we got together and with Professor Tupil Venkatesh, decided to do the second World Conference on Advances in COVID-19. This was in 2020, and this is my daughter, Natalia, who's also a medical doctor. After the meeting, it was a very successful meeting, very interesting stuff we presented. This was designed by Fatima, who showed at the end of the conference all the guests that we had invited. And this is the heart of India. That's what I wanted to mention to you, because this heart is also pumping for those suffering with ALS and MND. But there's a particularity in this picture. That's one of the reasons I brought it forth. You see this lady here? I'm trying to see if we can move on, but we're not moving on. And maybe there. You see that circle? That lady was the Minister of Health in La Paz at the time. I invited her to give her talk, and she did a wonderful job because she was a great Minister of Health at the time of COVID. She was in all the places caring for patients, giving equipment and so on. And she's a good friend of mine. So I asked her, please give a talk for this meeting. And she gave a talk. And she got sick with COVID, very severely sick. She got intubated and then recovered. But what was worse, later on, she presented ALS. I have talked to her about me coming to this conference, and she said, oh, please, I want to give you all the details. We really need to work with this. And as Basant Rao has created a beautiful foundation, she is also heading in the same direction, and she's passing through with a lot of difficulty, as you may understand. In South America, there is little awareness of the disease, but there's also smaller incidence. Obviously, the diagnosis is crucial, but this is the Union of Associations of ELA, is in Spanish, Esclerosis lateral amyotrophica, which is amyotrophic lateral sclerosis. And you see they're uniting to help with this. This is from the Stephen Bullrich Foundation. He was a senator. He was a senator in Argentina, and he, after his being senator, he also presented ALS. And he created a foundation. And now I'm uniting these foundations. I've asked Professor Mr. Basant Rao to link them, because we need to unite the whole world in this activity. And these are the different cities in South America. And if you can see in Argentina, this is the incidence, prevalence, male and female ratio, age, survival in months. But we're missing a lot of data, as you can see. Particularly in Bolivia, there was hardly any data. I moved around a lot. And you see, this is Bolivia, and that's where you are. And look at the size of Bolivia. And when you look at Bolivia, at the highlands, because we are part of the Andes, this right side, the west, is the Amazon. And that's where the biggest, largest city in Bolivia is located, around 2.5 million, in Santa Cruz, at 400 meters above sea level. Whereas I live in La Paz at between 3,100 and 4,100, where there's 2.1 million inhabitants, maybe a little more. But we're up in the mountain. And if you look at what has happened with COVID, when COVID started, I was asked for an interview to give my opinion what could happen before it arrived to the high altitude of La Paz. And in that interview, I said, we will have less COVID at high altitude than at sea level. And everybody said, What's wrong? This guy is crazy. There's less oxygen up there. People are getting lung disease. Probably they will be dying like crazy. Look what happened after. We have a lot of papers we published, and we have proved this on again and again. You see, in the lowlands of Santa Cruz, there were 9,043 deaths in total up to now due to COVID. But in La Paz, at this altitude, we only had 3,106, 1/3 less deaths. It confirmed my prognosis. Why did I make that prognosis? Because I know the benefits of chronic hypoxia. I know how the organism adapts to survive with less oxygen. You see, we fear less oxygen when it's acute and it's deadly and so on. But when you adapt, your organism becomes stronger. And this is extremely interesting because that's why, look, I ran around, I asked how many ALS cases in Santa Cruz. They were able to locate this previous doctor that was the Ministry of Health. She located 6. She said there may be some other one, but this is all we have found thus far. And then in La Paz, I went to the guy that's in charge of that, and guess how many we have? We had 2 last year, 1 died, and we have 1 this year. So I was surprised myself that there would be 1/3 less, just like in this case, you see, 1/3 less, 1/3 less. We probably do really have, but we need more statistics, of course. But it's highly probable. And you see, this info is given by Dr. Saul Pantoja in La Paz, who was located the doctors that work with searching for ALS, and the most important center is the security, health security system. The LALS info was given by Dr. A.D. Roca in Santa Cruz, the doctor that I mentioned. So it's based on finding. And by the way, Dr. Freddy Armijo is the current epidemiologist that has also helped us get the data. So when you are talking about the use of drugs in ALS, I'm not an expert in ALS or drugs, but I have read a lot, and I understand Relyvrio is an antisense oligonucleotide, sodium penyl butyrate and taurosodiol, also known as ursodoxycoltaurine. The idea is to protect the mitochondria and avoid axonal degeneration. Obviously, we're talking about prompt diagnosis, so that cells that conduct the nervous impulses to the muscles don't die. That's the clue to this disease. So remember, protect mitochondria. That's the most, apparently the most efficient, but it's still not absolute. You know that. So this is part of a paper I wrote with my daughter, Natalia, about 2 years ago, about the adaptation to altitude. You see, this is the normal sea levels of blood gases at sea level. And within the first 2 days, this is the first 2 days here on the right. Oh, I can use this. Yes, that's hard to use, the pulse. Anyway, blood pressure goes down. Pressure, barometric pressure goes down. Inspired oxygen pressure goes down. PaO2 and saturation go down. And so ventilation increases, cardiac function increases. Initially, carbon dioxide goes down, pH goes up, and that's why you have acute respiratory alkalosis. But the kidneys compensate, and it has been classified as chronic respiratory alkalosis, but I have proven through some other research how you should not interpret that as a chronic respiratory alkalosis, because we at high altitude also have a perfect balance of acid-base. So we call that normal acid-base status with these values, PaO2 60, PaCO2 30. But what I wanted to look, this is the first 2 days. After that, there's an intermediate stage, and then 40 days and beyond. You see this logarithmic curve? That's the increase of hemoglobin. That's how long it takes when someone comes to La Paz to achieve an optimal level of hemoglobin. And when that is achieved, these two functions, the two pumps, this is called the pneumodynamic pump and the the hemodynamic pump, can both rest because they're highly energy consuming pumps. So red blood cells take over in the transport of oxygen. But look at these other factors that increase the hypoxia inducible factors that have genetic expression and multiple molecular changes. The increase of erythropoietin, which brings forth the increase of hemoglobin, increase of nitrous oxide, increase of the vascular endothelial growth factor. What are all these trying to do? They're trying to improve transport to oxygen so that cells work efficiently in the hypoxic environment. And look what happens here. I wrote an increased myocardial efficiency. And when I sent this for publication, I got 16, I think 18 doctors that are well-known physiologists all over the world, and they criticized, no, you can't say there's an increase of mitochondrial efficiency. They observed that. Well, right now, this is published, and there is an increase of mitochondrial efficiency. So you remember the drug I showed you in the back? If you improve the mitochondrial efficiency with hypoxia, you are protecting the neurons. That's the concept behind this. So what happens with hemoglobin as you go up? You increase the number of the hemoglobin as you go up and adapt to high altitude. What happens to carbon dioxide as you go up? As you increase altitude, your carbon dioxide starts going down. Look at this, is at sea level it's 40. At the altitude of La Paz it's 30, and on Mount Everest it's 7. It's amazing that you have such low PaCO2 levels. So that's how we created the formula of tolerance to hypoxia. A high hemoglobin helps to tolerate more hypoxia, and a low carbon dioxide helps to tolerate hypoxia and improve the mitochondria. Now, what deficiencies are tolerable for survival? Look at this. If a living organism, such as that of a human, receives less water, you can die of dehydration. If you have no water, you die of dehydration. If you have less potassium, you can have a cardiac arrest. Less sodium and neurotransmission alterations, lower blood pressure, less chloride infections, less food starvation, vitamin C scurvy, vitamin B neuritis, less vitamin D osteoporosis, less immunity, less calcium osteoporosis, less zinc, less immunity, less magnesium, decreased bone density, altered nerve function, less selenium, altered mood, anxiety, less glucose, hypoglycemia, metabolic dysfunction, less fat, less cortisol, less proteins, less immunity, less essential amino acids. And so sometimes they're deadly. They're quite deadly. But look what happens with chronic exposure to less oxygen, chronic hypoxia. It's not deadly. Adaptation, more chances of survival. And I'll tell you why I said that. By the way, we created also the high altitude adaptation formula. Adaptation equals time over altitude. The higher you go, the more time you need for adaptation. And in our concept, you see the city of La Paz, it's growing more and more, many skyscrapers. In these cities, we are defeating hypoxia. And for us, this level of oxygen of 60 is normoxia for us, you know? And when I come down here to visit you guys, I am in hyperoxia. I'm receiving oxygen, a lot of oxygen, but my organism is adapted to tolerate very low levels of oxygen. Is that good? Definitely it's good, and I'll show you why. And my father, who was the founder of our institution, my mentor, said that man can adapt to any altitude, even the summit of Mount Everest. Imagine we could all adapt to live on the summit of Mount Everest. Now, let me tell you, in one of our conferences, we organized the chronic hypoxia symposiums. The fourth one was brought here to India by Professor Tupil Venkatesh. And we held it at DIPAS, the Global Hypoxia Summit and the fourth Chronic Hypoxia Symposium. Because DIPAS was interested, because you have to send doctors and army people to 6,000 meters to the frontier with Pakistan, you know? And obviously that's a fearful altitude for many, and many think, oh, I'm going to die. But every time I give a talk, some doctor comes up from here in India, some doctor comes up after the talk, says, you're right. I lived up there 1 year and I was fine, I did well, nothing happened to me. And actually, I tell them, you became stronger. Your organism learned to handle low oxygen levels. If something kills you at sea level, is low oxygen levels. If your organism learns to handle that, then you have greater chance of survival. So he wrote this: the organic systems of human beings and all other species tend towards adaptation to any environmental change within an optimal period of time, and never turn towards regression that inevitably leads to death. There can be no regression. Some people talked about loss of adaptation. He totally criticized that. He said everybody adapts, even those with disease adapt. So somebody asked me about this, so I put this slide. There was an article here that says that lung cancer incidence decreases with elevation, evidence for oxygen as an inhaled carcinogen. This was quite controversial, but it's true. It's true. You see, oxygen is a highly combustible gas. You put some fuel on it and it blows up. In fact, the rockets carry liquid oxygen as the propulsion combustible material. So in your lungs, the effect of oxygen is quite aggressive in the end. And I noticed that there was a man that lived 126 years in the high altitude of La Paz. I said, what? This is unbelievable. So I asked the National Geography, please give me the ages of all Bolivians, and I grouped them according to the city they were in. And this is what I found. And this was published by, this is going from the lowest Amazon cities that is 221 meters. You see, we go increasing. 416 is Santa Cruz, the highest, the largest population that I have shown you in the Amazon. Then Tarija, Cochabamba, and all these, as you see, will go increasing. And here's La Paz, where I live, at 3,800. And Potosí is a mining town where the great silver mine, the silver mountain called Cerro Rico de Potosí, was found during the colony times. You see how the people older than 100 years, we have an increase. The higher you live, the more you live. When I compared the data of Santa Cruz, I looked how many people older than 100 in all this data, and it was 6 people. And when I saw the one in La Paz, where I live, 48 people were older than 100. So you see, there is something there. That's how I began to think all these things. And I said, wait a minute, everybody fears hypoxia. It's the other way around. Now look, this is fascinating for this talk. Hypoxia extends lifespan and neurological function in a mouse model of aging. This has just recently come out. What they did is that there's this mouse that has an accelerated aging. They're born completely healthy, but they get old very fast. And what they did is we report that chronic continuous low percentage of oxygen. You see, normally it's 20.9. They put 11% oxygen. Commenced at 4 weeks of age, extends their lifespan by 50% and delays the onset of neurological debility in these mice. It's protecting the neurons. Isn't that amazing, Venkatesh? That's what I wanted to bring to show you. We have the opportunity that if you catch ALS early and you expose to hypoxia, you teach the mitochondria to handle hypoxia, there's an interesting possibility that this could be. Now, this is theoretical, of course. So when I was, where is COVID less deadly, at sea level or in highlands? I mentioned that to you about the chronic hypoxia challenge. And this is where they asked me in an interview in January the 1st, in 2020 in the university radio, and I told them we will have less COVID. And then come our papers, pathogens of SARS-CoV2 We found a lower, we suspected a lower amount of ACE2 receptors with some colleagues here from the University of Laval in Canada. Higher ultraviolet radiation at high altitude is what I proposed. We have much higher ultraviolet radiation, so it sterilizes the environment and it reduces the infection process. Decrease the incidence of virus transmission capacity and severity COVID at altitude on the American continent. And this is another one of our papers. You see how the incidence kept going lower, the higher you went. This is it has been confirming every time. The last study we did, we took 161 million people studied from Bolivia, Colombia, Ecuador, Peru, and Mexico that were diagnosed, that had run tests. And we found in all of them that you see on the left column is the lower altitude compared to higher altitude, higher than 2,500 meters. And you always see it's lower at high altitude. Also, erythropoietin is a very protective factor. This has to be also experimented in ALS. We have used erythropoietin in COVID, and it has been fabulous. We have saved all our patients using COVID in my care. We have saved all our patients using EPO in COVID. And you see, this is from another study we did, where we show that those with higher EPO were survivors as compared to those. Conclusion, exposure to chronic hypobaric hypoxia is mostly beneficial even during the COVID pandemic. And several other papers followed through with these concepts. So now, here in Bangalore, India, I want to introduce another concept that's originally, nobody has talked about this. This is, we question the term of acclimatization on exposure to high altitude. You see, all scientists in the world right now talk that you have to acclimatize when you go to high altitude. But climate, if you look at this, to acclimatize is to adapt to a different weather environment. That's why it's called climate. From a cold to a hot environment, from a humid to a dry environment, or vice versa, of course. That's what climate is. Climate comes from the Greek word, which means latitude. Change came to mean latitude, and the Earth was divided into 7 latitudinal regions originally. Acclimatize should not be used to refer to a change of altitude. You see, if you change LA for AL, you're almost with the same word, but this is not the same thing. And hence, variation of inspired oxygen tension. So temperature and humidity change in the same environment. For instance, in the morning, it's hot and cold, but you won't have more oxygen in the morning and less oxygen in the evening. So that you cannot apply a climate classification to hypoxia. So science requires absolute precision. So we propose to change the terminology. When referring to altitude change or inspired oxygen change, do not use acclimatize or acclimatization. You have to change that for hypoxize or hypoxization. It's different. You're being exposed to low oxygen, okay? So I am going to start using these new words. I'm never going to use acclimatization anymore because it's wrong. And because ice means to subject to. For instance, to subject to climate change is what that is. But this is not climate change. This is subject to hypoxia. So remember, hypoxize and hypoxization. So when changing altitude, oxygen pressures, when they change, when you go up the mountain, you are suffering hypoxization. And that's to hypoxize, is to reduce the inspired oxygen tension. Whereas if you're going down, you're suffering hyperoxization. You're getting more oxygen. Or to hyperoxize, which I'm doing now. I'm getting hyperoxization and I'm getting dizzy from so much oxygen. Okay, so that's increasing the inspired oxygen tension. So that term has to be dropped. That term has to be dropped. Okay, I hope you understand that. If life is so successful at altitudes in the cities of La Paz and Alto and Cerro de Pasco, man, being in his quest for intense instinctive survival, will leave planet Earth and travel through space. Is it important that all humans adapt to chronic hypoxia? I strongly believe it. I think you should all visit La Paz, learn, have your mitochondria adapt to use low oxygen. That makes you stronger. For instance, I have proposed that the space capsules should not use sea level pressure inside, because when they have to go out of the space capsule and put suits, they will go from a pressure of sea level to approximately a pressure of Mount Everest. And it takes more than 6 hours and a very complex system because you have to reduce. So what we are proposing, this has been for several years, that astronauts should be in an environment just like the city of La Paz. This will give them a lot of advantages. I don't have time to show you all the details about this, but the reasoning is that there's a faster preparation for extravehicular activity. There's an oxygen economy. Recall, we're going to Mars. Humans are going to Mars. India is going to go to Mars. It's on the track too. You don't have oxygen over there. So you have to adapt to lower oxygen. And there's a greater possibility of survival. So I created this new word because, you know, when they're talking about Mars, they need to make it like Earth. They call it terraforming. They're planning to create plants there so that oxygen will be produced. And then overall, that's the plan. It's a very complex thing. In about 100 years, they say that probably humans will be living there because there will be some production of oxygen and water and so on. So I said, but you forgot about the human factor or the biological factor. And that's why I created this word called biospace forming, because that means biospace forming is the adaptation of all living beings on Earth to space. This is plants, humans. We all have to adapt to space eventually to travel beyond, because we are at risk of this marvelous thing that nature has given us, which is life. Thus far, it has not been found elsewhere. Some people believe there is, but there isn't. If there would be, we would have already gotten the message, I'm sure. We already hear, we can hear the Big Bang when the universe started, but we can't hear anybody sending us a Morse code from somewhere out there. So that means, I'm sorry, but until they prove it otherwise, we're here alone in the universe, in my criteria. So we have to protect life. The first efficient biospace forming change is the exposure to chronic hypoxia. That's the first one. And this is to remember my father. Professor Venkatesh was at St. John's Medical College, and they named him the Mountain Guru in Bangalore, here, India, in 2009. He passed away, unfortunately, on 2000. He was a great guy. He would have really enjoyed meeting all of you. And this is the 3 generations. That was the last time we went to a conference in Peru. And this is my daughter, Natalia. We're all working in the same field. And this is the mountain of Sahama. And those are the llamas. Down here, the altitude is 4,100 meters, for 300. And in this mountain, at the summit, it's 6,542 meters. So you know that it's very flat in the mountain. So somebody said, do you think we could play a soccer game on the summit of Mount Sahama? We said with my father, of course we can. And those are the guys, and this is what happened. We carried them, we arranged it, and they went up there and played 20 minutes per side, and they tied up 2-2. Nobody died. They kept telling us, be careful, somebody's going to die. Nobody died. We painted the balls red, as you can see. They carried the goals up there. And in one of the occasions, one of the goals, the ball went down the mountain, and the reporter said the ball fell down to sea level, but it didn't fall down to sea level, just to 4,300 meters. But that's why we carried several balls. But anyway, we proved there that hypoxia, because these are guides and porters, they are always climbing the mountain, carrying the oxygen for those that climb up there. And so you can adapt remarkably well to high altitude. So basically, I have to ask, this is the city of La Paz from the view from my institute. And this is, I have to thank Natalia Subieta, Lucrecia, Dios, Rafaela, my great collaborators and family. Thank you very much.
Thank you, Dr. Gustavo.
No microphone. Yeah.
Somebody has a question.
Oh, good, good. Please, who has a question?
We can't do it pre-symptomatically, at least once they're very early ALS cases.
Yes.
So how would you want to apply this to the MND population?
Yes, we have a chamber. We have two versions of chambers in Bolivia. And that's correct. You have to, but you have to manage it. You have to have a lot of know-how how to handle it, because it has to be the precise amount, the intensity, the time frames, and so on. But that's the basic idea that we'll have to work on, doctor.
So do we have any data on hypoxic therapy for motor neuron disease patients?
For coronary disease?
No, for the MND patients. Do we
No,
have
no,
any
no, we
data?
don't have. I'm not working in that field, but this was just to put the ideas forth, to see if this is a new road to take.
So whether our MND patients should come to Bolivia and live?
In the early stages, probably yes.
Early stage, maybe they
Probably yes, doctor.
they may stabilize
Yes.
and not progress.
Yes.
So maybe
And
we should
have a longer lifespan and with better quality. Because once you know very well that, as you gave a beautiful talk about this, where I learned so much.
Thank
you see, if the neurons die, that's tough. If they can hold on, if their mitochondria work, they sustain, we got chances. That's what it is.
Thank you. Thank you. I think we should take this up as some collaborative work, and Mr. Vasantrao will facilitate taking some patients to Bolivia and keeping them there at high. Thank you so much.
Thank you very much, doctor.
very
Taking a line from you, I would like to ask you, Dr. Zubeto, whether it's possible to have a hyperbaric chamber in Bangalore?
A hypobaric, hypo, not hyper.
Hyperbaric chamber.
Yes.
And
Absolutely.
that could have the same effect of people going to Bolivia.
That's the chamber I have. I didn't show it, but I have the chambers, yes.
I think we could explore that,
Vasant,
Doctor.
there is one hyperbaric chamber on the airport road. Nobody's using. Maybe you can explore whether you can use it.
Doctor, you got a suggestion.
Thank you. Thank you. We look forward.
Okay. I am honored, not you. I am honored to hand over from Dr. Shama Narayan Foundation and NIMHANS a certificate of honor to you, grateful recognition of your scientific, contribution in a beautifully designed jacket by his brother. Like
Really?
I have a family
His brother?
working. He has a family working.
Oh, very beautiful. Thank you so much. Thank you, Venkatesh.
I hope your dream comes true. Maybe we'll be exporting ALS to La Paz.
And we'll see if I was right. Thank you very much. Thank you. Take my things, yes. No, but I could take it.
My another great friend from Italy, Padova. Padova, I visited a couple of times, where Professor Corrado Angelini is professor of neurology. He has worked on muscular dystrophy to a great depth. He also agreed to come like Gutsava, but because of his commitment in the Galileo's University, the chair is the Galileo's chair, and he will be delivering online a talk on ALS and MND. We are waiting for the connectivity. Pardon? Yeah, please. This is recorded talk. Okay, thank you.
Hello, I'm Corrado Angelini from University of Padua, and I want to talk to you today about a rare disorder, motor neuron disease. Doesn't progress the slide. Okay, here is my recent activity as editor-in-chief of Muscle, and who has papers to submit on the subject of motor neuron disease is obviously welcome. These are the aim of the journal I am editor-in-chief. Now, I will go directly to the subject. Muscles are a great part of the body, and in this disorder, motor neuron disease has an effect of muscle involvement. You have dysarthria and dysphagia, respiratory insufficiency for involvement of respiratory muscle, limb paralysis. ALS is a fatal neurodegenerative disorder, most common motor neuron disease in adults, and patients face a difficult prognosis. There are some symptomatic treatment and new treatments that I will cover, but most of the future will be done when we better understand its pathophysiology. Clinical patterns involve motor neuron signs, such as spasticity, loss of fine muscle movement, pseudobulbar syndrome, lower motor neuron signs, such as muscle atrophy, loss of strength, fasciculations. You can see a pattern of this rare disease that is familiar in 5% of cases and has a peak of age onset between 50 and 70 years, and the disease cures 3-6 years. Cramps are a common manifestation, and here are the reasons for cramps that are both to central nervous system damage, axonal hyperexcitability, and channelopathy. EMG in ALS is a cardinal exam and shows both active denervation and chronic denervation. Muscle biopsy is a group of atrophic thin fibers that are typical of ALS. Incidence is 2-3 per 100,000, prevalence 4.6, ratio male to female is 1.2 to 1.5, ALS are 5 per 15 familiar, for FLS, the rest are sporadic. You can see again the peak of onset in the group of 55 to 85 years and the female-male ratio. One useful way to diagnose ALS is to do transcranial magnetic stimulation that shows increased central motor conduction time. Potential risk factors to getting the disease are sport like soccer, fractures, trauma, military environment. For instance, the Gulf War reported a lot of increase in the soldiers, cigarette smoking, exposure to pesticide, organic toxin, electromagnetic or radiation stimulation. What has been observed from the beginning is a cognitive involvement. 15% of patients with ALS have frontotemporal dementia, and 20% of patients have a mild involvement of frontal function with semantic defects. Here is the report by Neumann in 2006 that found ubiquitinated TDP43 in frontotemporal lobal degeneration in the ALS, joining the pathogenesis of these two disorders. Here you can see with arrows the protein aggregation in neurons in ALS. For diagnosis, ALS requires lower motor neuron sign, upper neuron sign, and progression of symptoms. They were elaborated in the 2000 ALS Corial criteria that were done revised that divided ALS in clinically defined, clinically probable, clinically possible. But since there were several variants, these criteria were revised, and we use now the AVAIVI criteria that are modified ALS Corial criteria that are integrated with electrophysiological like EMG and other criteria and have a slight better sensitivity. Here are the ALS subtypes. We have the spinal onset, very common, bulbar onset that has the worst prognosis, progressive muscular atrophy, primary lateral sclerosis, and so on. As you can see in the spaghetti graph above, they have different course and different prognosis. These clinical ALS subtypes are mostly used, therefore, to the clinician to make a prognosis, and they go from typical ALS to the pseudo-polyneuritic ALS that start from lower extremities and has the better prognosis. Another way to make a diagnosis is to use biomarkers. Wet biomarkers are very useful. For instance, neurofilaments are used to confirm the diagnosis. As I said, ALS has both a familiar and a sporadic pattern. Therefore, we do a series of tests that you find here, but the most important are obviously those related to muscle, like creatine kinase and creatines, neurophysiological tests that I just described. And nowadays, we integrate the diagnosis with MRI study and genetic study. The biomarkers might proceed, especially for the C9 or familial ALS, the onset of ALS. Therefore, they might be useful when we have a treatment that nowadays is becoming available. The focus on C9 and ORF gene shows that the carriers of the gene can show both a frontotemporal dementia and the typical ALS. Therefore, the gene can originate both things. Here are the genes that are most common in familial ALS: TARDP 5%, PUS 5%, SOD1, that was the first gene found, 20%, and C9orf from 30 to 50%. Time matters. As a matter of fact, we have now a disposition for this disorder, the genetic disorder due to C9orf, an atlas study that is a prospective study, and antisense and oligonucleotides, tofersen, were approved by EMA and FDA, especially for, and are under the approval of EMA, for slowing down the deterioration of the genetic SOD1 ALS. There are other new treatments that are becoming available. These are approved by EMA, that is the European Committee for Medical Products for Human Use. IMix 0035, sodium phenylbutyrate, ursodoxycoltaurine, known also as tarursodiol, and they are under validation. What this treatment aims to do is to slow down the oxidative distress. Another drug that has been approved for slowing down the oxidative stress is edaravone, might give occasionally allergic reaction. Masitinib, that is against mast cell, is prolonging survival, has been approved, and is the second drug approved after Rilutec. So ALS is now, at least for the genetic, but also for the sporadic forms, specific treatments. Then there are symptomatic treatment that can improve cramp, depression, anxiety, sleep, but I will not go into all this detail. I will just describe later what are the results of neuroability, neuromotor activity, and respiratory and metabolic treatment. Here's a motor neuron that is, as you see, has many organs and can have, therefore, a lot of possibility to be treated. TDP43 is a small protein that controls mRNA maturation and is involved in the pathogenesis of ALS. Let's come now to other genetic forms that have seen great advancement in treatment. I'm talking about spinal muscular atrophy 1 to 4 and Kennedy disease, and I will shortly describe this form of motor neurons. These are all genetic disorders. Spinal muscular atrophy is an adult onset motor neuron disease due to androgen receptor mutation that is present in chromosome X and causes degeneration of spinal cord, atrophy of skeletal muscle, particularly of masticatory and deglutition muscle, as cramp and tremor. This is the androgen receptor that is mutated by an expansion in Kennedy disease, and therefore the diagnosis can be done through studying the androgen receptor. You can see here the fact that the biomarker like neurofilaments are present in ALS, as I just said, are not present in spinal atrophy or Kennedy disease. Therefore, this differentiated two disorders very easily. I will turn now to another disorder seen in the last years, a great advancement, SMA, for spinal muscular atrophy. There are 4 types of SMA with onset between 0 and 6 months. These children never sit. Between 7 and 18 months, never stand. Over 18 months, stand and walk. And the type 4 where they walk. Well, what has happened recently that through treatment, the natural history of this disorder has been completely changed. There are two genes that are involved in this disorder, SMN1, that is usually defective, and SMN2, that is a mirror gene that can be used to rescue this patient. So when we don't have SMN1 working, we can have various copies of SMN2, and depending from the copies of SMN2, there are different type of SMN, as I just shown. Here's an example in Italy of the prevalence of this disorder in Tuscany. As you can see here, we can have about 100 cases identified, and they go from Werning-Hoffmann disease, that is the infantile, to Kugel-Berwander disease, that is the adult form. Through this treatment that involves potentiating SMN2 in the case where SMN1 has exon 7 that is not working, we have now at disposition basically two types of SMN targeting therapies. It is one is AON, nusinersen, Spinraza, and more recently for SMN1, we have gene therapy that has changed, as I said, the treatment and allowed this patient to survive for a long time. We still don't know what the future holds because treatment has been started in recent years. So what about the future for the adult form of ALS? I mean, we hope to give them a better quality of life. And to do this, what I propose in this conference for ALS is to do an appropriate metabolic intervention. This should be precocious, optimized nutritional support, and people should support themselves to find out more therapies. What has been observed regarding metabolism and respiration is that patients with low cholesterol have worse respiratory function and prognosis in ALS. Patients with obesity and elevated cholesterol have better survival. And statins, that as you know, might decline cholesterol levels, have worsened the outcome in ALS. So also diabetes is not so unfavorable in this disease because diabetes might slow down disease onset by 4 years. This is the motor neuron that has many processes utilizing ATP. I will not go into them, but ATP maintains synaptic function, axonal transport, calcium homeostasis, endocytosis, and protein synthesis, all processes necessary for ALS. So there is a metabolic opportunity for the treatment of ALS. Neurons can utilize glucose, lactate, pyruvate, and the flux of pentose phosphate pathway. Besides this, they have around them astroglia that have a glycolytic metabolism and microglia. I will go into the intervention of these two types of cells around the motor neuron. We have written a paper regarding microglia polarization and mitochondrial metabolism in neurodegenerative disease, including ALS, and drugs that can prevent the microglia. You have to know that microglia can exist in two forms, M1 and M2. M1 is the bad, aggressive, pro-inflammatory microglia, M2 is the good protective. So the aim of using the drugs we propose is to have the microglia in an inactive protective state versus motor neuron. Another thing we propose to treat is the malnutrition in ALS. Clinical sign and progression of ALS can negatively affect nutritional status and are the following factors: dysphagia, hypermetabolic state, fatigue, and limb paralysis with difficulty in autonomous feeding, and difficulty for patient in maintaining the sitting posture. Here you can see the 4 factors that produce in amyotrophic lateral sclerosis malnutrition, reduced autonomy for use of upper limbs. Dysphagia is due to the bulbar muscle, calf and bulbar sign, and finally hypermetabolism. And I will go through especially hypermetabolism to clarify what can be done. When we have association of malnutrition and atrophy and inflammation, we have reduced neuromuscular function, muscular atrophy, dysphagia, pneumonia, and this produces inflammation and hypercatabolism. Dysphagia is present in 25% at onset in most of these patients, and in 75% during disease course. What is the major risk for patient is because of this dysphagia is that the food, instead of going through the esophagus and the stomach, goes to the lungs and causes an aspiration pneumonia. This might worsen the disease and aggravate the patients. There's a balance between the necessity to have a good caloric intake and its energetic utilization. The energetic utilization is the energy derived from food that is utilized from the patient, while the food intake is important to maintain a balance of these 2 factors. Hypermetabolism is, however, an adverse phenomenon that we observe in these patients. We call resting energy the one that is used to maintain body function, and this resting energy is represented by the factors that are used for the patient to maintain the following function: cardiorespiratory function, cerebral and peripheral nervous system activity, skeletal muscle biochemical homeostasis to balance ions, and muscle energy expenditure. Does not include energy necessary for physical activity or intake of food or fluids, and does not include also intermediary metabolism of different organs like liver, muscle, and so on. Hypermetabolism is an adverse factor in ALS and might cause respiratory fatigue, an inflammatory state, and even sympathetic system alteration. This is possibly due also from recent study done by my collaborator at the University of Padua that are studied when microRNA 1 and 6 by a transfer of small molecules that are called microRNA. Besides this, there are endocrine changes and there are mitochondrial alterations that are well known to occur in ALS. I want to show you the study that we have done on mitochondria, hypermetabolism, and oxidative stress. This is the motor neuron, and these are cytokines like TNF-alpha, interleukin-6, and so on, that have to do with the principal reaction in human body. And so TNF-alpha can influence the oxidative damage of DNA, protein, and lipids. And this is an adverse factor that you can prevent by a certain number of metabolic interventions. Mitochondria are the ones that produce the main part of reactive oxygen species. So what I propose is to do in patients for which we don't have so far a drug intervention, a therapeutic nutritional intervention. The extreme variability in onset and evolution of ALS subtype that I just demonstrated at the beginning of this lecture, and the necessity of careful surveillance of metabolic nutritional states is vital, since diagnosis of motor neuron disease and full appearance of malnutrition sign might precipitate a big deterioration of the disease. Malnutrition or protein and caloric malnutrition is indicated when we have low body mass index, BMI below 18, is an adverse prognostic factor and might increase death risk 7.7 times. So it's important that the team, doctor, nutritionist, physical therapist, has a surveillance of the nutritional status of ALS patients. What is the level that we recommend of therapeutic nutritional intervention? On the basis of nutritional status and the grade of dysphagia, we prescribe normal diet when the oral way is possible, or a diet modified with nutritional integrator and gel condensers to increase food and drink consistency in ALS with dysphagia. And we end up also proposing to individual patients enter artificial home nutrition by pack that prolongs their survival. I want to go into the models that we have studied. We studied ALS mice muscle, and we have studied the respiratory control ratio and cytochrome oxidase activity that are both effective in the mice. Then we have gone to patients, and these are the results that are not yet published, that I have obtained in sporadic and genetic disorder, normalized for milligram of protein, and normalized for citrate synthetase, that is the major component of the mitochondria. So you can see that sporadic ALS and SOD1 ALS has lower activity of complex 4, that is cytochrome oxidase, respect to C9orf controls. When this is normalized for citrate synthetase, we still see that sporadic ALS and SOD1 ALS have lower complex 4 respect to C9orf ALS and control. So on this basis, we propose to add to the available medical therapy that I just presented before, that is riluzole, that is the most used treatment that has anti-glutamatergic action, prolongs life of a few months, and edaravone that I just illustrated, and is an antioxidant activity against Ross mitochondria, and has been approved since 2017, a therapy with metabolic factors that counteract the mitochondrial oxidative stress. Creatine supplementation that was experimented in SOD1 mice, coenzyme Q experimenting SOD1 and IMPA, and finally pramipexole that also anti-oxidative. In addition, diet high in calories using fatty acids, ketogenic diets, and triglyceride diet with medium chain fatty acid using octanoic, heptanoic, and trioctanoic acid, experimental now in animals. In addition, you can use acetylcarnitine that has been proven by Beggy to be beneficial with riluzole, but needs a further phase 3 trial. I will short in the last minute present our study on microRNA. These are small non-coding RNA. A single mRNA can regulate hundreds of genes. And MIR1, MIR133, and MIR206 are specific for skeletal muscle. Here are the function. Basically, MIR1 is heart, and 133 are present in myoblast proliferation. MIR206 is the most important because it's present in the synapse and myoblast differentiation. We have observed in patients serum during 6 weeks of rehabilitation that all this microRNA decline is a negative regulator. That means the muscle mass improves. Conclusion. I have said that ALS has a catabolic effect on nutritional status. ALS pathogenesis is complex, involves oxidative DAGE and microglia. Accurate monitoring of nutrition during respiratory and rehabilitative treatment is needed. MicroRNA are biomarker both for diagnosis and rehabilitation. Dysphagia determines decreased quality of life and nutritional status. And my suggestion is to use diet, energetic compound in ALS, and this should be further trial in patients. Thank you. Hello, I'm Corrado Angelini from University of Padua, and I want to talk to you today about a rare disorder.
Oh, well, the light that was lit in the morning still continues. There is hope for a discovery of a drug for MND. Thank you all. For today, the session comes to a close. Please have tea and have a network with the various vendors that are there. And tomorrow we meet at 10 o'clock. We have a lot of exciting speakers tomorrow, and I'm sure you'll enjoy as much as you enjoyed today. Thank you once again. Thank you very much. Hello, just one moment, please. Mr. Corrado Angeli has come online now. 1 minute, we'll just stay with him for a while. I'm sorry. One minute. I think yeah, Mr. Corrado Angeli, good evening. I think you are on mute.
I can hear, but I didn't hear the question.
Yeah, Dr. Corrado Angeli is asking if there are any questions for him.
Professor Angelini, can you hear me? Am I audible to you?
Hello, Tupil.
I just before your talk, there was a talk on hypoxia and possibilities of managing the ALD patients by Professor Gustavo. Professor Gustavo is also like you from high altitude lower and high. Professor Gustavo is here, and he is proposing for certain changes in the mitochondria and the hypoxic condition, which might probably support in the care of ALS and MND patients. Your views about that?
So, I didn't hear the question, but I enjoyed your session and the proposal also to, bring patient to hypoxia that can be done, as I heard, also in Bangalore, because you have an hypoxia chamber. So I think you should experiment some of the ideas that came out to this meeting and offer to the patient both new treatments and hypoxia, chronic hypoxia, to find out what happens.
Thank you. Thank you.
Sir, I'm Dr. Thomas from St. John's, Bangalore.
Yes.
So we use Edravon. We are using high dose vitamin injections and Riluzole for many years. So we did not find any major improvement in patients with MND. In Edravon, a few group of maybe around 10% of people feel their fasciculations are less, pain is less. Sometimes a little improvement in motor power we see, but it is not sustained. So what is your experience with Edravon and how long do you see? And many patients are sad because these infusions have to be taken every 2 weeks. So it's very difficult to give the infusions. And now oral Edravon is up. That's what the people are coming. Some oral form of Edravon is coming. So any information on oral Edravon and what's your experience with all these high dose vitamin, what's your experience on the treatments, what we are giving now for motor neuron disease?
Well, as you know, Endavaron is used in certain category of patients with a restrictive indication of certain categories, and has been done on the basis that seems to be rescue, to give some rescue to the free radical status. Regarding the vitamin you are using, I didn't get which vitamin you are exactly proposing. Vitamin.
Japanese had a publication telling high dose injection vitamin 25 to 50 milligram alternate days may delay the progress in early motor neuron disease. And we don't have injection which has high dose. Our injection is only 1 milligram, around 1000 milligram. What they propose is 25 to 50 milligram IM. So what we do now for few patients, which is oral tablets, we calculate approximately the dose and give the oral tablet. And few patients early had little benefit, but not sustained.
Well, it is difficult to comment because you are using a different dose from the Japanese study. Of course, we all know that these are all symptomatic treatment. So even if the Japanese found some improvement, there might be some slowdown. But so far, even for the treatment that are more promising, like the one that are tofersen and so on, we still see only a slowdown of the disease, but we don't see in any case a reversal of the motor impairment. So my guess is that we have to go to a combination of treatments. We have probably to combine different treatment, Endavaron, high dose vitamin, and maybe also this environment factor that were proposed today, like chronic hypoxia, and we might get a slowdown of the disease, but it's a long way to demonstrate efficacy since, appropriate treatment group are difficult to find and you need a lot of patients that can be available in long and expensive trials.
So one more question regarding the etiology. We are all exposed to toxins from birth, from toothpaste to food items to these things. Can be all this degenerative be toxic rather than any other etiology? That's why we are not getting any solution till now.
What can be toxic, excuse me?
From toothpaste to everything. From toothpaste to everything is a toxin we are putting for many years. From
Yeah,
50
there are
years.
several toxins that have demonstrated to cause ALS. Of course, you know, this comes mostly from studies from epidemiologists. For instance, when the United States did the tremendous Gulf War, there was a big increase in the number of arrests in the warrior. And then there were a number of studies that were done, even in the first studies in Guam and so on, that demonstrated a lot of toxin can cause motor neuron disease. And it's well known that pesticide might increase the risk of ALS. So our environment, unfortunately, is getting worse and worse, and wars are still there. We have the Ukrainian war, we have an environment that is very unfavorable. So it is not surprised that motor neuron disease is increasing now at times. I heard with great interest that in certain environments like La Paz, there is less incidence of ALS. We still don't have this as a solid epidemiological data, but we certainly know that most of the environment that so far is present, the wars and the radiation, will be toxic on the long run for motor neuron.
Professor H. Mobashiri, you have a question?
Yes, please, if I may.
Please go ahead.
Thank you very much, Professor Briani, for a very fascinating talk and organizer of such a nice meeting addressing such an important matter in the world. You mentioned about the electromagnetic field effect and possible side effect of electromagnetic fields and a possible cause of ALS. We are working on the single ion channel. It is calcium dependent potassium channel of the inner membrane of the mitochondria. And we have noticed that irradiation of the cell phone can drastically damage the channel activity of this very channel at single channel level. So as you mentioned, the mitochondrial activity is matter as well. How much do you think human being exposure to electromagnetic field caused by cell phones, by antenna, and so on, can cause damage on the mitochondria that leads to ALS or increase the risk of ALS? In other words, is it possible to somehow correlate the number of people who are infected or who are dealing with the ALS with the amount of exposure, their exposure to electromagnetic fields? Thank you very much.
Well, that's a very good question by Professor Mubashir. Unfortunately, the evidence rests mostly on anecdotic cases. People that have been electric shocked or fulgurated and then developed ALS in the same extremity where they got electric shock. Regarding your question of the small cell phone, this is certainly something that is overused today, and I think brings every kind of damage to the brain, but I'm not sure that causes ALS, you know. So we have just to stay on the fact that the cell phone should not be used by younger people for a more behavioral problem, but should they cause, how they say, acoustic neuroma or ALS? For acoustic neuroma, there are some evidence that there are some acoustic neuroma depending on from cell phone. For ALS, evidence is still missing. Thank you for your question.
All right, thank you very much. Thank you.
Goodbye to everybody.
If there are any more questions, I think Professor Anjali will be very happy to answer. I think we have one more question. Professor Anjali, thank you very much. We really enjoyed your session.
Okay, enjoy taking part in your conference.
Professor Anjali, I think
have a good wish for your activity that is necessary and useful.
Professor Anjali, I think Zubito has something to say.
Yeah.
Look at the camera. Hello there. Hello, Professor.
Hello.
Professor Venkatesh has asked me to meet you and discuss this hypoxic stuff. So I will be looking forward to getting a joint meeting with you. I know you're a president of the European Mountain Society or something like that. Did you hear me?
Okay. Thank you. I enjoyed your talk. I couldn't understand your question because of microphone issue, but I hope to meet you sometime and visit La Paz and also Bangalore again.
Thank you. Thank you, Professor Anjali. And with this particular session, I think we will have tea and we'll assemble again tomorrow morning. Thank you very much.